Thank you so much for coming this morning. I'm very excited to get to spend the next few hours with you talking about looking beyond operational data and connecting to outcome and quality data. So this is very exciting. Welcome to the AAOE 2019 annual conference in Nashville. This is an exciting conference. Hopefully it'll be a great session this morning too. We'll talk about this more. We really want to engage you in some discussion. It's a large group, but that is even better for discussion. There's more opportunities for people to participate. So you'll see a lot of opportunities to connect, ask questions, share ideas. You know, a lot of the things that we're going to be talking about, you know, it's not a final roadmap. So the more ideas that we can share, the better that we are going to be able to learn from each other. So it's not just about learning from us, it's about learning from each other. So again, thank you all for coming today. By way of introductions, I am Vicki Sprague. I'm the Senior Director of Data Solutions and Operations for AAOE.
And I am Bradley Coffey. I'm the Manager of Data Services and Government Affairs for AAOE. Many of you knew me as the Government Affairs Manager before, but Vicki liked what I was doing so much that I moved over into both government affairs and data services now.
All right, so before we get started, some of you may have heard us talk about a data warehouse that was launched in 2018 last year. We are rebranding it here at the conference, so you're going to be hearing a lot about AAOE Empower. And there's even an AAOE Empower station that if you want any more information from us after the session, you have questions, you want to take a look at some of the technology live and in person, come to the Empower station, going to be located next to the registration desk on the Delta level. So come talk to us. You can schedule one-on-one times to meet with me, with Brad, or our data analyst, Daniel, to get additional questions, answers, get started in the benchmarking survey, get connected to AAOE Empower, whatever your next step is, we can help you with that. So just wanted to give a shout out to that and start. And so we will be talking about AAOE Empower a lot more towards the end of the session, but just want to, if you want to go ahead and schedule some office hours, there's the link for you to get started. There we go. All right, so a few housekeeping notes. Just some basic ones, appreciate, we are recording the session. This is actually being live streamed this morning, so anyone watching, that's not physically at the Gaylord here, welcome to you as well. We're excited to share this information with everyone. Some information about fire exit, social media. We have, session evaluation is in the app this year, and you need to fill, those evaluations are helpful to us to improve the conference, and they're going to be required to access some of that CEU information. So, and we will update and verify the CEU information at the end of the session.
Yeah.
All right. So again, what we're talking about here, laying the foundation for the elements of what we're talking about here in terms of operational data, satisfaction, outcome, and quality data, and then talking about some advanced insights. So, really, we have a lot of learning objectives for this. We're, again, excited that we have the opportunity to do it as a pre-conference session. So we have 3 hours to have some really great conversation. You'll see that we're going to talk about how to make connections among a lot of data. So as orthopedic practice administrators and staff, you collect a lot of data on a wide variety of things on a daily basis. And the goal with this is really to have all access to what you need in one location and be able to look at what you're doing to other industry orthopedic practices, so the professionals, the experts in the industry, so you can really have the data that you need to be successful for your providers, for your patients, for your practice, in your community, and then to contribute to the industry as a whole. So lofty goals for what we're talking about here, but really important to your day-to-day as well as that bigger picture. So I'm going to just take you on the vision for this. As I said, we launched AAOE Empower in 2018, and the reason we did this, we've been collecting these operational metrics for many years. We've been doing a benchmarking survey at AAOE for over 20 years. So we're all used to some of these metrics in terms of operations, but we started to think, there's more to it, especially as we're moving into value-based care, satisfaction metrics, outcomes, and quality measures are so important. You're going to need to report that quality data to get your MIPS points. You're going to need to collect outcomes to really understand how you're doing for your patients. So we knew it was more than just benchmarking, so we wanted to add in these other data elements. And then we started to think, what if we can connect these operational data elements in with those patient-centered metrics in one location? So you didn't have to have 5 different ways of capturing and looking at and seeking out benchmarks. You can find it in one simple location. So that's where the vision behind AAOE Empower came from and what we're going to talk about today. So we're excited to share this with you, and we will start digging into some of these concepts. So for those of you that are familiar, operational benchmarks, again, what do we mean when we're talking about this? So these are the categories that are included in the benchmarking survey. Whether you've participated in AAOE's benchmarking survey, MGMA, there's many others out there. We're not the only benchmarking survey. A lot of the ones that are out there tend to capture these general areas. These are what are important for orthopedic practices. These are similar in content to what's being out there in other specialties in terms of medical practices, and we'll talk about that a little bit in a moment too. But just wanted to start familiarizing yourselves with the areas that we're talking about when we say operational metrics. What are the things that are included? And again, I'll go into this a little bit in more detail. But what do we mean when we say benchmarking? Let's, take a moment to make sure we understand what that is. Providing you a couple definitions on this slide. And really for me, it's really that opportunity to, you look at your practice data on a daily basis. You understand your metrics really. You know where your revenue is, where your expenses are, your overhead, all these things that you look on a daily basis. But there's moments it's like, how do I know what I'm looking at is right? Is it good? You need that comparison point. You need to be able to say, how did my data look compared to somebody else, right? And those comparison groups are hard to find. So the benchmarking process allows you to look at your practice and compare it to others, whether it's a national data set or if you're able to customize it by certain practice sizes, certain areas of geography, whether it's a region or a state, or look at it by in other comparison groups. Who can you compare it that makes sense, that makes that data meaningful, and say, yeah, I'm doing okay because it is the same as what other orthopedic practices are experiencing. So that is my own definition of this in terms of what we're talking about here today. All right, so other things that are important. So, I said there's lots of different benchmarking surveys out there. Here, when you try to consider what surveys to participate, what sources of data to seek out, these are the things that we feel are important to consider when you're looking for what comparisons to look. You need to be able to compare, as I said, your practice to industry averages and there's benchmarks. Okay, you should be able to have a direct comparison or a way to make that direct comparison. You need to be able to examine trends over time. Again, in your practices, you probably have a sense of how your data trends. How is your overhead this year compared to last year? How is your physician compensation comparing this year to 3 years ago? That's important, but are those trends in your practice consistent with what we're seeing at a national level? So if you're going in the opposite direction, trending-wise, as the industry as a whole, that might be an area of concern. Or maybe you're just doing well while everybody else is going down. Okay, that's good to know. You're doing something right. Then the opportunity is, what can we learn from you? It's to correct that so the industry as a whole is having improvements in really powerful ways. So those trends are really important part of this as well. And you need to be able to, start to combine. What are the impacts of variables on results? If you change something over here, how does it impact something in another area, whether that's another operational metric or in these areas of outcomes and satisfaction? So that gets into some of the connections. So how do we really have the access to the data we need and a broad enough brush of things so that we can really make really good connections? And then consider, do you want to compare yourselves to other orthopedic practices? Is it good to sometimes look out and compare yourself to other specialties? That's always a consideration when you're looking at all the surveys that are out there. So again, these are just things to consider. And, really participating is important. Participating in some sort of benchmarking process or accessing that data can be really powerful for you in your practice. So this is an example of a benchmarking report that exists in AAOE Empower. And I just wanted to highlight the basic functionality so you can have a visual for those of you that haven't seen the AAOE benchmarking results. You have a way to look and kind of visualize what we're talking about when we're talking about a benchmarking report. So what you're seeing here are the blue bars are the industry averages. The black bars that you see here is actually your practice data. So this is obviously just default data kind of, but the black bar can be your practice. So you can see side by side how your practice is performing compared to that industry average. That's very powerful to be able to do that in one location. And then the lines represent the 25th percentile, the median, the 75th percentile, and then the 90th percentile. So then you can not only just, you can look and say, where do I want to be? I'm a practice, and I'm talking about compensation. It's important to my physicians that we are at the 75th percentile. I want to be paid higher than average or higher than median. So it's very important to bring those in. So you can say, I'm going to look at the 75th percentile across all these metrics and compare. So it's more than just averages. That's where we're doing. So you can see where you are. I'm better than 75% of other practices on this particular metric. So that's what you're seeing in terms of those benchmarks. The dial on the right gives you that exact percentile number for your practice on that metric. And then on the left are some filters, right? So it's like, okay, you pull up a report, you have your comparison to all practices who have participated in the survey. But you might not want to compare yourself to all practices because there's likely many things that make your practice unique. You're a small practice, you have one doc, whereas the other practices might have 30 physicians. You are located in Alaska or Florida or California, and that's going to be different on many variables than if you're located in another state. So you want to be able to compare yourself to just other practices in your state. So applying a state or a regional filter so you can really look at how some of those geographical factors can play into things. Specialty, what are the specialty of your physicians? If they're a spine surgeon, some of these results will be different than if you're total joints or so on. All right. So we wanted to take a moment and really highlight what reports and what metrics are included in the AAOE benchmarking results and how they compare to metrics that are included more broadly in medical practices. So here is some information from the source noted on your slide that says these are some key metrics and ratios that you see across the medical community. These align in a lot of ways to what we have included in the benchmarking results, but not exactly. And some of the things that are the deviation is because we've worked hard to make sure that the metrics that are included in the benchmarking results are relevant to orthopedic practices. So we'll note some deviations on this, or if you go back to this, it's like, well, we don't have something that's exactly like one of these points. It's because we are customizing it for orthopedic practices and emphasizing things like productivity and how it's measured for orthopedic surgeons. All right, so a few years ago, we have an AAOE Data Analytics and Benchmarking Council, and they felt, we had, 30, 40, 50 reports in our benchmarking results. That's a lot of data, especially if you are new to benchmarking at all. So it was like, how do we help people get started in the survey? So they went through a process of identifying 18 core metrics that are the starting point, right? So if you're new and if you don't look at anything else, pick one or two of these 18 reports, start there, really dig in and understand how your data compares to those industry averages in these areas, start tracking these data points. So what I'm going to walk through with you are the categories of data and what these 18 reports look like at a high level so you have access to that information. So the first is revenue, right? Revenue is everybody's number one. How much money is coming in to the practice? How does that compare to other practices on whatever variable you want to look at? Pretty clear there. The second one is productivity, right? And so this is one of the things that we really focus on. There are lots of different ways to measure productivity for orthopedic surgeons. We've combined this so you have access to a wide variety of things, and at different times, different questions that you have that come up, any one of these productivity measures might be relevant to you. Sometimes it's surgical cases. Work RVUs are important, and there's a lot of conversation around work RVUs, whether or not they're related to your compensation model whether you use that to inform your compensation model, is something useful to track for benchmarking purposes, because it really provides that standardization across practices and gets out of some of the nuances that exist across specialties and things like that. So if you want to talk more about that at some point, we'd be happy to have that discussion as well. The next category is the first reason a lot of practices might seek us out and say, do you have data? Because somebody's asking for a raise. You might want to raise as a practice administrator. Well, how can I look at how I'm being paid? How does that compare to other practice administrators in similar sized practices or with practices that have different specialties represented, whatever? You can come here and say, this is how my compensation compares to other orthopedic administrators. And we're really working on even improving the amount of data we have in this particular area. So you have things about years of experience and credentials and things like that to consider when you're looking in these results as well. And then obviously physician compensation. Am I being paid? I'm a spine doctor. Am I being paid enough? And your doctors might say, I need to change my compensation model because I'm not being paid enough. Let's look at that before we just go down that path, right? Let's see if is there a concern, or are we actually have something and we're competitive with others in the same market, for the same specialty, in the same regions and so on. So it's a starting point to say this is something to look into more or something we need to table for now. And that data that you can provide back to your physicians can be so powerful to manage those conversations. It's not just their reaction, their experience in talking to their friend in another practice or working at the hospital or whatever it might be.
Yeah, and Vicki, if I can say something.
Sure.
So I've heard specifically from several members, how frustrating it is. Their physician comes into their office and says, you know what, I read in Becker's that, hand surgeons are making $500,000 a year. I want that. There's some issues with that because Becker's isn't always looking at specialty specific data. They're looking at MGMA or AMGA, or, they're just going and interviewing a physician and saying, how much do you make? And they're getting a very small sample size. I think what's really important is looking at sort of what that sample size is, how it's distributed, and, that really gets to whether that data is reliable and valid. And if you can make reliable and valid decisions based on that data, then that's really important. And you're going to get a much better deal for the money that you're going to be paying to that surgeon. So just something to think about. I don't know if anybody else has had a conversation with a physician like that. I've heard Becker's is a 4-letter word around here. So I just wanted to throw that out there.
Great, thank you. All right, so some additional metrics. Overhead, expenses, how we're spending money, obviously is a huge area. There's many more reports. There's not just these two, but these are two that made that top 18 list. Overhead, staff costs, we'll talk about that a lot today, in terms of how you manage that. And I think overhead is tricky, some of these things, because it's not higher, better, lower, better, right? If you go too high or too low, you're going to feel it in your practice from different, perspective. So there's an optimal range that exists there, and you kind of, through the other things that we'll talk about, you'll get a sense of when you're too far one way or the other. But these obviously are very important benchmarks for us. So this is staffing, so we talked about cost in terms of expenses and overhead, but now let's talk about our staffing levels. Again, too high, too low can be a problem. So getting the right, how many staff do we have? How many do other practices have of a certain category or certain type? That's really helpful to say, should I be adding more staff, or do I have more staff or too many staff? So let's look at this and see other practices in similar circumstances, what are their staffing levels, and be able to learn from that and incorporate it into our practice. And then, there's a set of reports, everything's important. When you're growing as a practice, when do we need more space? We're talking about square footage, it's a very detailed thing, but it can be very powerful. It's like, is there a ratio that exists for what should your, square footage be as percentage of revenue? So if I'm making this much money, I probably have these many providers, so I need this much space in order to do that. If you add ancillary services, when do I need more office space to accommodate those? Those are questions that you don't immediately probably think, oh, I need to benchmark that, but you do, as part of the process, and how you connect these reports together are very important. So we really tried to look across all the things that you manage as administrators to look at what is really important and what needs to be tracked in these core metrics. So the final set here are percentage of total AR, your accounts receivable, are your collections coming in as efficiently as other practices? If there's rooms to learn from other practices because they have nothing in 120 days and over, and you have more than you want there, can we learn from each other to make improvements in our practice so that we're getting those collections taken care of right away? And payer mix, so important. If you're looking at your own payer mix, how it compares to others, might not in itself be a point of interest at that moment, but if you're looking at compensation or productivity or net collections or other things, it's like, my payer mix looks different than this comparison group. So I need to take this into consideration when I'm looking at some of these other factors, because it might be that you're not getting collections or your productivity levels are different because of the population you're serving and how those contracts are written. So another point to really think through. And then number of x-rays per x-ray technician, we have this as a core report. There are a lot of other volume-related metrics for other ancillary services, for physical therapy, for MRI, for DME, but we highlight this as a core report because most practices have x-ray. They may not have all those other ancillary services. So that there are other ancillaries represented in the benchmarking survey as well. So as we wrap up this piece on the benchmarking, again, I want to reiterate, it's so important to participate in benchmarking. Figure out, the return on investment can be really great. It relies on everybody though, right? It's like, we obviously want people to purchase the results and have access to that whenever they need it. When you participate in our survey, you get the results for free. So we know there's a time commitment required for that, but you're going to get so much value out of it. And we can talk a lot about that return on investment here at the annual conference. There's a session even with that title in it if you want to go check that out. But really, know that data, when you have access it and when you need it, is so important. That's really, you're going to be armed with data that allows you to make decisions in a way that maybe you haven't before, or if you're already in those reports, that you have experience. And we can talk a little bit about that, examples of how that has helped you in your practice. And then again, the trending information is very important. So participating consistently every year can really provide insight into how you're doing and then what those trends are. So just when you're looking at and considering whether to participate in benchmarking, keep some of these factors in mind. All right, questions? So that was a lot about benchmarking. So how many of you have participated in the AAOE benchmarking survey before? Okay. Good majority. That's exciting. There's several of you that haven't. So yeah. So that's great. What do you guys, maybe either side of the coin, as you participants, as you consider participating every year, what do you think are the biggest barriers to participating, and maybe some advice to those that haven't participated in the past of why you do it? Go ahead. Now I got a mic too so that we can capture our responses here.
Thank you, Vicki. The biggest barrier for me is the same four-letter word as going to be for you, and that's time, right? Mostly because our P&L doesn't always match exactly how AAOE is collecting it, but I find it certainly worth the time for sure. The main reason I've always participated, but the main reason and the ideal reason I need it now is that the MGMA data is just, gradually going down, and there's not enough of a data set to actually have data come back, even if you participate. So I have called Vicki and said, you're on, you're it. That's all I got. And, we're going to have to get this going because I'm going to have your data to show my docs we're either good, bad, or indifferent. So they really enjoy the fact that we have something to measure against that's, just orthopedics. And that's very well done and very well measured. So thank you all for your work.
Thank you. Anyone else? share. Don't let the microphone intimidate you. We're trying to make sure we have a good recording. Anybody else want to talk about the return on investment, or, what it would take to get started? It's like maybe somebody that just participated the first time last year, what really allowed you to participate, and your thoughts on the experience.
Vicki, this is not about a first timer, but it is encouragement for everyone to join. As a participant for a while in the benchmarking, and then going through a transition of a merger, last year I had an incredibly difficult time engaging other folks on the team to get me the data that I needed. So I didn't participate. And within a month or so, folks walked into me and said, we need this data. We need these percentages right away from you. And I ended up buying the benchmark survey last year. So it's valuable. If you can participate, you should.
All right, thank you. Anyone else? Anyone have questions related to the benchmarking survey that you want to?
How many groups total participate? Because that's always my fear, is that just not enough are in it. So I just want to make sure that.
Yeah, so that's where we need to work together, right? We have last year we had 175 practices participate in the survey, which it's been at that level for a couple years, but allows you to apply, really filter down maybe to regional level and to those specialty areas in most cases. To look at most the practice sizes. The goal for us is to get to 300 surveys. So if we can work together to get to that 300 surveys, represents, a third of our membership. The amount of filters you can apply and the way you can add 2 or 3 filters at a time is going to increase. So we need to work together on that. But, right around between, I think we'll get to 200 this year. So you have that additional data. So, yeah. I have another question. Oh, sorry. You took the microphone back there. I didn't see it.
Sorry. I'm brand new to this, brand new to ortho. We have a brand new group that just started. So I don't know a lot about it. But, so when is the data submitted, and how do you get the information on what I don't really know anything about this. How do you get started?
Sure, yeah, and we can talk to more about this after the session at the Power Station. But so the survey is open now. It actually launched on March 14th. It is open till June 1st. And it's an online survey. So if you haven't already received your benchmarking survey link, we can make sure you have it and have a chance to look at the survey before you leave conference. We will send it to you. So make sure I know your practice name and your name afterwards. The links were sent via email directly from AAOE Empower. So if that link didn't make it to the right person or you didn't receive it, let us know and we'll make sure you get it. And then you can start on the survey. We have resources, helps you walk through the process. There's a survey guide built into the survey. There are videos that you can watch to kind of orient you to the survey. There's checklists that you can download to say, here's the data that will be included, and really walk you through that process. There's also a session this afternoon on completing the benchmarking survey, where we have a couple experts in here that are going to really do a deep dive into that session too. So that's another great way to get started. So, yeah, so look for those links. And if you're not a member and you're interested in participating, I'd be happy to send you a survey too. It's not a requirement that you're a member. So either way. Okay, maybe one more question and then we'll. Sorry. Talk to me after.
If you fill the survey out, are you able to just contribute portions of the data instead of everything if your practice isn't necessarily sophisticated enough to add everything yet?
Yes, absolutely. We know that's a concern. That's one way that we've addressed the time factor that Jim mentioned earlier too is, yeah, complete as much as the survey as you can. Know that the more data that you contribute, the more access to results you're going to have that compares your practice to others. Obviously, you can think through, the compensation data, the revenue and expense data. Some of that's very valuable. And we can talk with you about what makes sense for you to contribute as well. So we had somebody over here. I think. Okay.
We got one over here. If you could pass that down.
Hey, can you just talk for a minute about kind of the operational data itself? Like how many practices, how many physicians right now are participating in the survey, and what that looks like in terms of the market?
Yeah, so I answered a little bit in terms of practices, about 175 practices, and that represents like 3,800 to 4,000 physicians across the country, and additional providers. So you have compensation data for nurse practitioners and physician assistants as well. And that, the market is much larger than that. AAOE doesn't represent every orthopedic practice in the country. So as we grow in membership, the participation in the survey will continue to grow as well. Okay, we do have one more question. She's been patiently waiting up here, and then we'll move on.
Great. I just wanted to mention being able to submit our OrthoForum benchmarking report, and this has been very helpful. So based on that, we've been participating every year. So the OrthoForum and OrthoConnect members that complete the survey, which is mandatory for the members, I think that's a great way just to send it in as is, and that really helps a lot.
Yeah, absolutely. If you are in that situation, you're an OrthoForum, OrthoConnect's member, you can send that survey directly to me. You have my contact information, I'll give you my card, and you can send that directly, and then we take care of incorporating that into benchmarking results.
Yeah, and real quick before we move on from that topic, even though I know you want to move on, I do want to make a brief note about the way we use data for government affairs. So it's a very important topic. Medicare is always trying to take your money. The more data we have, the better we can represent you in Washington. Just as an example, right now AAOE is working with the National Osteoporosis Foundation to try and raise the reimbursement for DEXA scans provided in a physician office. I know that's something that a lot of orthopedic practices aren't able to provide because the reimbursement as it stands right now is at about $40 a scan. It's not enough to break even. We're trying to get that increased to $98, but we need that data to know exactly just how it's affecting our industry. A lot of legislation, regulation, it's written based on the data specialty groups and groups like AAOE provide. So the more data that you can provide, the more effective we can be in Washington, D.C. Okay. So I get the fantastic task of talking about the patient-centered benchmarks. Unlike the operational benchmarks that we've been talking about, patient-centered benchmarks are relatively new both to AAOE and to the broader field of data in healthcare in general. Patient-centered benchmarks are really benchmarks that are derived from data that is supplied by the patient. So whether that's through a patient survey, really those are the main patient-centered benchmarks that we have, are patient survey data. These benchmarks are becoming increasingly important as payers expand reimbursement policies to those based on the value of care provided rather than fee for service. So these are just some of the key domains of patient-centered benchmarking. These are pulled from different surveys. We'll go over that in just a minute. And now the perfectionist in me is looking at that communication and realizing that that's messed up. The purpose of patient-centered data is to really focus on improving the quality of care. So as you can see from this slide, we've got patient-reported outcomes, quality, and patient satisfaction data. This is the data that's supported through AAOE Empower, and we hope that in the future we can grow that list, but you can sort of see how improving quality of care is front and center there among all those. Patient satisfaction, its goal is to really improve practice improvement, provider experience, and recommendations or referrals. The dimensions of patient satisfaction really come from what's known as the CG CAPS, the Clinician and Group CAPS study. This is a survey that was created by the Agency for Healthcare Research and Quality, which is a part of the Department of Health and Human Services. We use the CG CAPS, a shortened version of that, in AAOE Empower, along with the Net Promoter Score, to really get at that focus on patient satisfaction. We're asking the questions that are most related to the aspects of satisfaction that are most important, as well as whether or not a patient is going to go out and actually tell a friend or a family member, you should go and see Dr. So-and-so because they did a great job with me. That's what that Net Promoter Score is trying to get at. Patient-reported outcomes. think this says it's you.
Yeah, I can take that.
I was short.
Yeah, so, satisfaction is a great place to get started too. We can talk about where you are with that too, sending out the surveys, looking across all the satisfaction measures. The same core components exist across many different surveys, so we just really needed to find one that to start with, which is why we mentioned the CAPS. So patient-reported outcomes is an area that we need to be moving to. So if you talk about and look at this diagram, you're probably familiar with quality measures to some extent because there's a requirement to report quality measures. You're, familiar with satisfaction surveys because we all complete them every day. We all have satisfactions, and it's pretty easy to get a satisfaction survey built and sent out and start using that data. Outcomes equally as important, but probably not on as many people's radar, right? It's kind of the next step. It's so important though, because really understanding those functional outcomes for our patients is very important, and it's relevant for our providers. They want to know whether they're providing the best care possible to their patients. They became surgeons because they want to help their patients. So knowing the actual improvement and the improvement rates for their patients, how does it compare to other orthopedic physicians, in their specialty, across specialties, however they want to look at it. So in being able to say we have higher outcome rates than, our neighbors or our competitors in this market, that can be very beneficial for you as a practice too. So, think about outcomes when you're thinking about how are we positioning ourselves. And we'll talk about other ways that outcome measures being used too, but when you're negotiating with your insurers for new contracts, you're trying to position a lot of these things. If you can say we have high satisfaction, really great outcomes that are better than average, that can really be powerful when you're having conversations in a variety of ways across everything that you do, negotiations, contracts, you name it, and you guys can probably give me more examples. So this is why we created a way to do this, and I think it really levels up orthopedic industry as a whole. So if we as an orthopedic industry can say, this is where we're doing really well, or these outcomes are not ideal, how can we learn from one another and go back to our physicians and say, these outcomes are lower for this specialty than others, and that's how we all can improve, right? The providers then are going to be able to provide better care to their patients. So that's why outcomes is one of the cornerstones of what we're talking about. So what do we mean when we say a patient-reported outcome survey? These are the starting points. So when we started to do this, I looked at hundreds of different patient-reported outcome measures. There's a lot out there. There's a lot out there that are relevant to orthopedic practices. But obviously, if we're going to create benchmarks on patient-reported outcomes, we can't use all available patient-reported outcome measures. We needed to start somewhere. So we had a measures task force that was convened that reviewed the ones we identified as the starting point and said which ones of these should we include so that the majority of members would have something that really they can respond to and react to. It's going to be relevant to their practice. So this was the starting point. And hopefully when you look at this list, you'll think about the doctors in your practice, think about their specialty areas. There should be one or two of these that apply to a physician in your practice. The promise is a global measure. So if you have pain specialists in your practice, maybe that's a way to start for that physician. But, if you have somebody doing total joints or knee surgeries, the Coos Jr., the Hoos Jr., those two are probably the most common starting point. But again, it really depends on your practice. If you're doing upper extremities, you have measures for that. So really this set is what is built up in the system. You can start with those, and the conversation needs to continue. Did we miss something? Do we need to add additional? Because the majority of practice is like, well, I'd do it if you had this one other survey. We can talk about that. But this was just meant to be the starting point, and we've gotten good feedback that this is a good starting point. If you want to look at these surveys and learn more about them, obviously let us know. One thing to note about these surveys, when you're doing satisfaction surveys, you can add questions to get additional feedback. You can customize and say, I love your survey, but I have these two that my physicians insist that they have included in their satisfaction survey. We can take that starting point, add those additional questions. It's easy to do for a lot of satisfaction surveys. Outcome surveys are a little bit different animal because they are validated instruments and they have developers that really want to protect their intellectual property rights and things like that. So you can't add questions to those outcome surveys as easily and still have them compare the scores to others. But, that's part of the science behind what we're doing. So I just want to make that note and distinguish that between the outcome surveys and satisfaction surveys.
Yeah, and I think it's important to note, if you're not collecting outcomes data just yet, this is definitely the track that Medicare and a lot of third-party payers are on. We've heard from some practices that groups like Blue Cross Blue Shield are starting to require collection of the COOS data. Medicare right now it's voluntary, but eventually it will be required. So it's good to go ahead and get started on it now. While it's voluntary, figure out your processes, your workflows for it, and then when it's required, it's much less burdensome on you at that time. Because obviously this is what Medicare feels is most relevant to physicians. And, they're the largest payer in the United States. So what Medicare does, everybody else does too. You guys are well aware of that, but, just wanted to throw that out there.
Sure. All right. So let's talk. So how many of you are currently collecting patient satisfaction survey data in your practice? Okay. Probably about a little more than half, I'd say. How many of you are currently collecting patient reported outcome measures or surveys in your practice? Okay, about the same. Some groups that I do that, there's the satisfaction survey is a much greater number than the outcomes. So that was more equal than a lot. So good job. Because I do think, building up to that and understanding that both satisfaction, outcomes, and quality is important, is, a journey, right? Because we're just moving into this area. How many of you are collecting quality measures for whatever reason? Okay. Yeah, a little less than surveys. Yeah, so it's an evolution. What we're required to report really drives what we do. And the goal that we'll talk about with the quality surveys coming, I'm not stealing Brad's thunder here, but, quality measures are required for reporting, but really it's going to be valuable to us if we look at that in terms of benchmarking the same way we do everything else, right? We want to be able to compare how we're doing. So think to your process about collecting patient-reported outcome measures, patient satisfaction surveys, and talk with me about what is working well and what are the challenges. As you got started or where you are, what are the challenges to your process? What's working well? What have you found to be really effective for your practice that we all need to consider as we're starting satisfaction surveys, or if you're seeking help on getting those surveys to your patients and using the data. I'll just start us off. Thank you.
Okay, so our practice uses the Who's and Coos, and we do it on pretty much everybody, and then we do it before surgery, then we follow up with them at 6 months. And one thing that we've noticed is that there are a few people at the 6 months that are not still having good outcomes. So it gives us an opportunity to bring them back in, re-x-ray, and reevaluate what their needs are. And sometimes it's just the fact that we do it on, especially our Medicare patients, you're finding out that there was not enough mobility, enough, PT, things that they needed to start out at the beginning. So we kind of reset their clocks and go forward. So that's where we found, from a clinical perspective, Who's and Coos is very effective.
Yeah, that's valuable, and to be able to catch it and say, based on your results, I want you to come in, because if they hadn't had a patient or appointment scheduled, you might have missed that opportunity, and if they're not reaching out to you. Yeah, so in the long term, you're really improving outcomes. That's a great example of how that data can be helpful. Anybody have either a success story or barriers that they had to overcome to make things work, or other comments? Since somebody rose to put their hand down when I specified the question. Thank you.
Good morning. I think that it's more of an observation that I think that the more visible and more public patient satisfaction becomes the Google or Yelp or Health Grades online reputation management, that the physicians are sensitive to, and so that's where the focus ends up becoming, perhaps at the expense of collecting more meaningful data, because we don't want to be sending every patient 3 surveys depending upon what it is we're trying to understand about their experience. So maybe my question is, how do other practices navigate through that balance of hearing from patients?
Anybody want to respond to that from an experience? Any takers? Yeah, you're perplexed, the audience here. Yeah, really getting that feedback from patients, right? Is just like, and really making sure that we get it timely. Is that really the essence of the question? Right. They're being asked too many times. Right. Yeah. And how, some people have asked, how do we make those patient satisfaction surveys and something, as soon as they come in, we know about it. So maybe we can respond to a survey that comes in before they do post it. Tell us on our survey that we send you before you go out and do those scores. And some of this is that social reputation management of, do you have people that are looking at that to say, there's concern, or is there a bad review out there? We're going to take it, and how can we take control? So, I think there are moving parts in that, right? So it's, how do you have data, from your patients, and then how does that intersect with all those other social media sites out there? And, how can we, I think it's a workflow too. Some of the things I hear about is, if you're educating your patients on, we are going to be serving you, we really want to hear from you so that we can improve our practice. That's another way that prevents them. So I'm going to talk to my practice rather than going and saying a bad review on Google, because they invited it. They asked me for this feedback. They welcomed it, and they actually responded then too if it was a bad experience. I think that can be very powerful. So, that we'll talk about workflows in a little bit here, but preparing your patients for the survey process, letting them know it's coming and that you're really committed to that improvement is going to be an important part of that. I think there's probably a whole nother talk on the social reputation movement. People are asked to do Yelp and health grades and things like that. So it's, how do we, use any data we do have to prepare them to give good reviews and know when to say, talk to us. So I started to answer that question. I did not fully answer it. Does anyone else have any comments to build on what I said?
A couple of points. Something that we're doing, maybe from a marketing perspective, because this is where the idea came from. As our patients are waiting in our lobby, they're using our Wi-Fi. And so after they leave the clinic, we send them a message, how was your experience? Let us know how it went. And we're finding that anybody that's got a complaint or has a bad experience is welcoming that opportunity to tell us about it right away, and so we can prevent it from going online. And we have to be very responsive to them immediately and take care of their problem in order for that to work. And then on the survey side, we found that we can't overload people with requests for information, and we've had a much better success in getting surveys completed in the office, which is time consuming, but I think it goes back to the education side of it and letting people know how important the information is.
Right. Absolutely. And, we'll talk about opportunities to capture this data while the patient is in your practice, because that has come up many times. It's like, if you have follow-up appointments with the patient and they need to do an outcome survey, have them do that right there, so we have, we'll talk about opportunities to do that on a mobile app right in your office, right? So you could pull up the survey, give them a device that they can complete it, and they can get it done right there, rather than having to send it when they leave, because you've lost that opportunity to capture that data. So that is important to this process and survey results.
Vicki, I love my survey, but the limitations of my survey are that It doesn't compare kind of my information with others. And secondly, it doesn't count for CJ caps. And so I'm trying to figure out a way, if y'all can help us develop that so that we can submit it for caps and get credit, at least for some of the questions, for our quality.
Yeah. So there's a couple things in that question, so you say you have a survey that you love, right? And that works well, but it's not the one that's approved for MIPS. So that kind of, yeah. So there's two different sides to that. So because there's the very specific quality measure that includes the caps for MIPS, and you have to be, if you know about that, you have to be a certified survey vendor in order to do that caps for MIPS piece. We are not a certified survey vendor. That, is probably a longer term goal than a shorter term goal. But there are other ways that you can take advantage of your satisfaction survey process, whether you're doing a satisfaction survey and you're doing improvement activities related on the results of that survey. That is improvement activities points in terms of MIPS. So there are ways to leverage what you're doing in terms of satisfaction to that. So your patients are familiar with, if you use the, either the full caps or a shorter version of the caps that we have embedded in the system, your patients will be used to responding to those surveys throughout the year. Like a new patient visit, you get that. And then if they get the call or they go through the, certified survey vendor for the MIPS reporting, they're more likely to complete that process. So, it's not the direct, maybe that's something that Brad can help us advocate a little bit more. That's a very specific process that CMS has set up for that. But the question would be, is there an advantage to familiarizing patients with those questions prior to that formal caps for MIPS process, or are there other ways you can get the points so that you don't have to, rely as much on that one piece? Might be another option. Do you have anything to add to that particular?
Not really. I think you covered it pretty well.
Okay.
Like Vicki said, caps for MIPS is really a longer-term goal for us, simply because of that rigorous process that CMS has set up to qualify for that. We're 9 staff for the association, and that would at least double what we currently have.
Other questions?
Okay.
You don't need this, you need this?
Yes.
Okay.
Okay, so I get to talk about quality measures now. So discussing the use of quality measures almost always starts with what's required for MIPS, or the merit-based incentive payment system. So how many of you are actually participating in MIPS? Okay, quite a few. How many of you aren't participating in MIPS but are participating in an advanced alternative payment model? Fewer. It's about what we expect. MIPS is a very popular program simply because it's required, but because the requirements for it are a little bit easier than some of the advanced alternative payment models. So, MIPS is obviously very important, and it allows a common framework on which we can begin to discuss and understand quality measurement. However, the use of quality measures can extend beyond regulatory reporting if they're used within the same benchmarking model that we've discussed throughout the presentation. And quality measures will become more relevant when we as an orthopedic community develop measures that are truly relevant to orthopedic practices. So AAOE does have an approved registry with CMS, the AAOE Registry, that is a part of AAOE Empower. It's approved for the MIPS program, and that gives you a good entrance into sort of collecting that data and allows us to effectively benchmark that data for you. So we'll talk a little bit about what that looks like. So these are what we'll show here in just a minute are the measures supported by the AAOE Registry. Right now what we're seeing are the national quality strategy domains for improvement. These are what CMS uses to actually break out all the different quality measures into categories, so to speak. So you can see this is communication and care coordination. These are the measures we support for that. Community and population health, effective clinical care, patient safety, and person and caregiver-centered care. So one thing that you'll notice is communication and care coordination and effective clinical care are sort of where we have the most measures that the AAOE Registry supports. And this isn't by accident. So when we were actually going through and selecting these measures, we worked with a group of AAOE members to look through all the quality measures that currently exist and say what's most likely for that AAOE members would be reporting on behalf of their eligible clinicians. Looking across these domains, the orthopedic community, as I said, is obviously focused most heavily on communication and care coordination and effective clinical care. This sort of reflects the nature of the orthopedic specialty. You don't really deal a whole lot with community or population health. You deal a lot with patient safety, but not really person and caregiver-centered care. As specialists, you're not a part of that. You're a part of the patient-centered medical home, but you're not the provider that is directing a lot of that. That's generally primary care. So it's just a very interesting note to make about sort of as the process we went through to get these, some characteristics of the specialty actually came out. So one thing that we would say is select your measures strategically. Measures are worth a certain number of points according to CMS's set benchmarks. Easier measures may be topped out, and thus it's really difficult to get the 10 points for that particular measure. And CMS actually added another wrinkle to it this year, where if it's severely topped out, the most you can get is 7 points. So even if they have a benchmark for 10 points, you won't get 10 points. Even if you get 100%, you'll only get 7 points for that measure. And even having those conversations with CMS, what was that, 3 weeks ago? I've been traveling so much.
Right.
It's felt like a little bit, it's felt like longer, but, about 3 weeks ago I was in Baltimore meeting with CMS and they said they're going to start getting rid of the topped out measures. And they're actually going to start getting rid of the process measures too. So those are concerns that we might have about some of these, quality measures. But getting back on track, you shouldn't just be selecting measures simply because they're easy to report. Those topped out measures, there's a reason that CMS has topped them out because they're fairly simple to report. So things like smoking cessation, while it's very important and it deals a lot with the actual clinical outcomes, how long it takes somebody to recover, it's a fairly simple measure to report. Do you smoke? Stop it. That's really all that takes. And then you document that you had that conversation with them. CMS is trying to make these more like stretch goals. So you have to work a little bit harder to get to it. We can talk about whether or not that's a good way to encourage physicians to report this data. I would say it's probably not. You got to do stuff that works within their workflows and works with them as experts in their field, but they don't always listen to me. As I said, we just want to make sure that we are selecting measures that are important and relevant, clinically relevant. And as I said earlier, I think that'll happen as we're developing some of our own measures. That's not something that AAOE is planning on doing right away, but it is something that we see in the future, working as a society, but also working with other groups out there. So working with physical therapists, surgeons, other groups that might have clinical specialties that can provide some of that clinical expertise with us. Okay, let's talk about patient-centered data. So I guess the first question that we have are what are some of the barriers that you're finding to data collection, whether it's for quality measures, patient satisfaction, or patient-reported outcomes?
Anything that we haven't touched on already?
I guess let's just narrow it down. What are some of the barriers you're facing to quality measure collection? Patients not wanting to have the difficult conversations or not wanting to fill out the surveys that might be required for a quality measurement.
Yeah.
Staff participation.
Okay.
So staff participation and making sure there's consistency in the data collected.
Right.
Yeah.
Some of that comes from the staff, the physicians, staff has collected it through EMR, and then people don't do it. You send them, nasty memos about getting it done. You do this carrot and stick, and still you don't have enough data. So that's a problem for us.
Right. Yeah. Just not enough data. Not enough. Yeah. Yeah. It has to be consistent. You have to have those responses in order to get the volume that's required.
Yeah, because Medicare bakes that right into the regulation. You've got to have 60% of all of your Medicare, all of your patients. You have to have those conversations, or you have to have data for them. And if they meet the denominator, then they're eligible for it. it's really difficult to have those conversations with all those patients, or even get all those patients to fill out the surveys that are required or something. Whatever the required is. My physician sends me surveys all the time and I never fill them out. So, even though I do what I do, I'm the biggest hypocrite in the world. But, it is. And, I think to the point earlier, patients are given we get a lot of emails every day. And, it's just prioritizing. And then, I don't go look at my email and see that from my physician and say, oh, I'm not going to fill that out. He doesn't care what I think. It's generally because I've forgotten about it. So I think reminders are incredibly important. And then even working on those workflows with your staff about, this is how we want, the smoking cessation conversation documented. Medicare puts in there a very specific code to use for having that conversation. So even just saying, we want this code used to denote whether you did it or not. If you did it, you put this one. If you didn't do it, you put this one.
Yeah. Well, another thing I'll add to that, and I think that's why, when you're talking about which measures to select, we're going to those easiest ones, right? So whatever challenge you face in some of those measures that are easy, those check boxes, really what we should, if we're doing quality measurement well, right, and want to really elevate our specialty, orthopedic practices, we'd be collecting those measures that are most relevant to orthopedic practices. Some of those require the functional outcome assessments, which, some of these things aren't just checking a process and making sure it's done. It's digging into it a little bit more and really assessing, what was done, what was that change. So they might be harder to track, but they're more meaningful for orthopedics. So how do we resolve some of these workflow issues so we're actually capturing the most meaningful quality measures and really driving the change for orthopedics as an industry? So I think that's the challenge before us, so that we are really pushing the envelope and making sure that providers have the information they need to improve, right? Because that for our patients, and there is a reason that we have quality measures, is because we want to, CMS, healthcare as a whole really wants to make sure that everyone is properly focused on those quality pieces, and we need to focus on the ones that are so important for our patients. So it's going to be an ongoing process, figuring out some of these things, staff collecting data consistently. How do we do that when we need information back from our patients? So that, I think there's a lot to learn. Definitely, I don't have all the answers, but we need to work on this together to some extent, because that's where we're really going to be able to keep orthopedic successful and constantly improving. So I think that's an important thing to focus on.
I agree. And I also think it's important that we as an industry be doing it rather than relying on Medicare to do it. Yes, it's easy to sit and complain that Medicare is doing this, Medicare is doing that. I do it frequently. I call my parents. They have no idea what I'm talking about, but they listen. So that's good. But if we're taking care of it as an industry, and we can create quality measures. We can create a framework around which to do this, that it works within your practices rather than Medicare. And there are very smart people working at Medicare, but the reality is very few of them have ever worked in a clinical environment. They all went to their fancy schools, got their degrees, and then went straight into government service, the federal bureaucracy. So they don't have that experience, most of them. So I think it's very important that we be engaged with that. We developed quality measures. We develop the workflows. We develop all this stuff, and we can go to Medicare and say, look, we've already created this. Why are you duplicating it? Just use ours. Now it's an open question whether they will. But, the simple fact is if we've got it, we've got it. They can't, it's more difficult for them to justify expending the resources to develop their own regulations rather than just saying, oh, this is what orthopedics is doing, so let's just go with that. We'll let them continue that, and we'll base our reimbursement strategy around that. So maybe that's a little optimistic, but I really think that's how we get the change that we're seeking with this. Okay, so what's the return on investment that you're looking for when reporting these quality measurements, or these quality measures? Is it being able to benchmark? Is it just getting the reimbursements that you had hoped you would get from Medicare? Bueller?
How many are you doing collecting quality measures because you're required to do it? How many of you feel like you're collecting quality measures because you're getting additional value from those measures? Yeah. See, this is the conversation we need to change, right? Yeah. That is fundamentally why we're here, trying to say we have a bigger vision for this, right? Because quality measures are so important to really make sure that we are doing good work. You know, some of it's in those outcomes, and there's a lot of quality measures that are based on the outcomes, so that connection is important. You know, but, you know, my vision for this is in 5-10 years, when I ask that same sequence of questions, you're like, quality measures are important. You know, the right measures are important for my practice because they allow us to improve. That's the conversation we need to have as AAOE community, to say, how can we make sure we have the right quality measures available to us so that we're doing it because it helps us as a practice, because your staff will get bought into a process if you can help them see how it helps them grow and improve. So right now, if you're just doing it because somebody external to your practice is telling you to, it's the same way, you know, as we're motivated as kids, right? And it's like, if I believe in it and it's something I want to do, I'm going to be in it. But if mom or dad says I have to do it and not really passionate about it, it's much harder to get that buy-in. Question back here. We are on.
I think it's kind of on the return on investment and the barrier. The problem for I think a lot of practices is it's so time consuming to understand what has to happen and educate and collect the data and analyze the data that it's really hard to get to the point where you can do something with it because you're spending so much time figuring out how to get everybody to do it, to do the education. I'm sure we all, you know, time is the most valuable thing. And then working with the EMR systems, you know, they look at every measure as an individual task. So if you follow what they tell you to follow exactly as they prescribe it, your staff have to go through multiple steps over and over again. My EMR company probably doesn't love me, but I push back on them all the time. We build it in as structured data. We add clinical rule engines so that I don't have to educate, 55 medical assistants on how to collect the data. I build it in the system, and as long as they're following a process, it continuously offers logical answers and logical information to them. But, that takes time too. Mm-hmm. And so, that's the return on investment, but it's also the barrier to collecting these things is that, everything, it takes too much time. Right? So.
Yeah, and let's face it, we'll say a lot of the EHR companies out there haven't made it easy. We've heard from a lot of groups that you have to buy the quality portion for the EHR, or you have to buy something else in addition to get that functionality that you were describing. And, medical practices as a whole, especially orthopedics, I think are hit up for money many times. I think there needs to be many things that change, and that's one of them. And, AAOE submitted comments saying essentially that back in January as part of draft strategy on health IT. We're sick of being charged all this money and not getting that return on investment.
Yeah, and I think that's another point that was made there is like we're just collecting it. You have to do all the education on how to collect the data, and then you're getting your successful submission into CMS, and it's like you're done. Can we actually look at the data afterwards and say, this is why this is important beyond that requirement? I think that's a great piece for us to take and others to say, how do we help you have access to reports, make that data usable? So you've collected it, you were required to collect it, you collect it, and let's make it useful for our practice beyond just that one piece. And I think that is a next step for orthopedics as a whole, and probably for the whole quality program in many ways.
I have a little comment on that return to investment. I think 100% on when you're talking about quality, you have to have the physicians backing, number one. If you don't have them backing and participating in quality metrics, then your staff's not going to buy in. So the physicians purchase the product. They need to support it as well to your staff, because we all know as clinical people at one time or nurses that their focus is making sure they're devoted to making sure that that physician runs smoothly and clearly. So if he's giving that feedback to their staff that that's something he wants done, we then implemented in a quality RN. I was 100% adamant about it. She follows these people. She collects the surveys. She does the work in the clinic that the clinic RNs are like, one more thing. So it's her one more thing to follow. And then we incorporated the data into our peer review process per department. So we generate them quarterly, review them as a department along with the other things we do, and make sure that we're looking at the data we're collecting. Because if we're not, it's foolish, to not do it. So it's worked being part of the peer review process. It's actually been really well received. And the physicians look at their individual data, their partners' data, and then what we're doing as a, compared to other people.
Right.
Quarterly.
That's great.
Yeah. So if you don't have the people to put towards quality, it's going to fail.
Right. Yeah. Thank you for that. There was a lot of good pieces of advice in there. And you were right, staff, physician buy-in, absolutely. And working with the physicians, if the physicians are focused on the right measures, that'll help advance things too. It's not just the easiest thing. It's what is the most meaningful. Did you have a comment?
Yeah. Reviewing the data after is super important. Our office had a success story with it because I work for great surgeons, but we did have some outcomes that weren't as successful as we wanted, and we were like, what is going on? So by looking at the data and going back through it, we were able to figure out why those outcomes were happening, and we ended up creating policies for actually our total joint surgeries. They have rules now. Before a patient can be scheduled for a surgery, they have to meet certain requirements like the smoking cessation, BMI, A1C levels. And so as an office, we have noticed a big difference in our outcomes because of this new policy that we put in place based off of the data that was reviewed. So it is a process, but again, having the physicians on board is super important. But the physicians were on board because it's their outcomes. They want their patients to be successful. And anyway, so it is great. Don't just collect the data, review it after, because it really can help your practice and your providers.
Yeah, thank you. All right.
Okay. Do you want to take a break?
Well, what I would like to do is we will take a break in like 5 minutes. I want to queue you up for the rest of it to make sure you come back, because we're just getting started here in terms of what is really going to be valuable for this session. So, it's 3 hours, too long to sit, so we are going to give you a short break. But I'm going to revisit this a little bit because we've talked separately now about the benchmarking survey, right, and all the operational data that goes into that. And then, we've seen this slide. We talked about the value-based metrics, the patient-centered metrics in terms of satisfaction, outcomes, and quality, and why we thought it was important to connect these together into one place. Right? So if we have these two images, what we're going to talk about after break is how these things intersect. Start making connections between the operational data and the satisfaction survey. How making connections between elements of the operational data and outcomes, and really tying this together, because independently we had a great conversation about how some of this is usable. If you have access to the data, how you can use it for quality improvement, how you're able to make changes. But imagine, if we had all this data in one place and you can see how things in one area is doing that affects the other, what we can do with those connections. So, what we're doing is really saying, how can we pull these data together? Again, you've seen the slide. But let's look at this. We have all of these distinct components, right? All these individual components of the benchmarking survey that are these operational metrics. We talked about all these categories: revenue and expenses, compensation, accounts receivable, and then on the other side, all the patient-centered metrics, scheduling, how much time was spent with the patient, did we provide good quality of care? What if we're bringing all this together into one place and we can have data on both of these pieces? Let's start thinking about the connections we make. We have identified some connections that we think we'll be able to make using this data. Some of you may have already started to make these connections. But as we go into break, let's think about how can we use all this data together to really improve the quality of care, to empower your practice, to focus on those areas of improvement, to help yourselves internally, help your providers be more successful, better care for your patients, you to operate more efficiently. So what we're going to do is really take this together. So I'm getting to the slide. So when we come back, let's talk about this. We can start, once you start thinking about, what are these connections? What are you thinking about? So when we get back, let's have a little bit of where are you, in terms of some of these initial connections, and then we'll go through the connections that we see to generate some more thinking and thought process on that. So it is 10:18, so 5-10 minutes. So I want to start before 10:30. Okay? All right, so we can go back. Yeah, my voice does not carry. Sometimes you need Brad's voice to carry through and make sure that we're all back. Thank you so much again for sticking with us here. Really hope that we're going to present some thought-provoking things that are starting points again. You know, this is really the core of our session. Really want to talk about how to pull some of these things together. So again, we'll have a lot of discussion opportunities for you to share your ideas so we can continue to build on what we're presenting here. So get ready to think. You know, you had a break. We're re-energized, ready to go. Let's start making some of these connections. You know, this is a really great slide. You know, it's just like, why are we doing this? And we'll see this again, you know, just looking at some of these, we mentioned it already. Just don't want to glance over that because these are the reasons we're saying we want to collect all of this information because there's so many ways that this data can be useful. Okay, so let's look at this a little bit piece by piece. So I'm not going to go by domain by subject through the benchmarking survey, but we are categorizing these operational metrics in a few different ways. So let's just start with business requirements. Whether you are in medical practice or a company, you know, you have revenue and expenses and you have overhead and your bottom line, what you're trying to get to is your net income, right? How much are you making? What is your profit margin? Every company looks at this. So these are what we're going to call business requirements and why we have to collect this. We have to collect this because this is what keeps our businesses in operation, right? If we're not paying attention to this, we're not going to be here in 2 years, 6 months, right? So this is the starting point for us all. We're responsible for managing our revenue, our expenses, our net income. So that is the starting point for everybody. But then let's talk about how this starts building, okay? So obviously, in order to get revenue, we have to do our things, right? For orthopedic practices, we measure it productivity. It's doing new patient visits, getting new patients, seeing those patients, identifying when they need a surgery, performing the surgeries, and then all that turns into collections from your patients. Okay, that's how we as in orthopedic practices get our revenue, right? So there are obvious connections here. So the more visits that we do, the more surgeries that we do, the more money that we will be bringing in. So again, not surprising, but obviously there's strong connections here between the work that our providers do and the revenue that's coming into the practice. So, you know, as we go forward, there's a lot of things that we're going to say, you know, how do we maximize the number of visits and surgeries that we're doing while we're not sacrificing those quality and outcome metrics that we're going to talk about later. So then, you know, again, not surprising. There's a lot of connections here, though. You know, obviously a priority for our physicians is compensation. So the more that they're productive, that they are seeing more patients, they're doing those surgeries, that is directly tied to their compensation. No matter what type of compensation model you have in your practice, you know, your physicians get paid more when they are seeing more people bringing in more money. Heard a child crying or something in the back if you saw a few of us. Pause there for a second. So obviously that's a number one priority. I think if I had a show of hands, everybody say one of the top things that we're concerned about is making sure that our physicians are happy in terms of the amount of money that they're bringing home. There's obviously a direct line between physician compensation and productivity. There is a direct line between productivity and provider compensation, right? So they're going to get paid, and at least, you know, from their salary and bonuses, right? So it's probably a little less direct. But, you know, obviously the productivity and how successful our surgeons are is related to how U.S. practice administrators are being paid and your staff, right? So if we have more money available to support our staff, we're going to be able to hire more people or maybe pay the staff that we have more, right? Give bonuses to practice administrators. So again, there's a relationship, as it is in any practice, between the amount of revenue that you're bringing in and the compensation that you're able to provide throughout the organization. So it's a very direct line for physicians in terms of their compensation, but obviously it's important for all staff in the company as well. All right. So now we're going to start, these were the easy ones, right? Those were the easy connections. You could have talked me through that piece. Let's start talking, and we're going to get started, and then hopefully you can help us add to these. Let's talk about patient satisfaction and how it connects to these operational metrics. So staffing levels, and for staffing and overhead, it's not more staff is better, right? There's an optimal range. So the goal here is to maximize the patient experience, right? We need to have the right number of staff to be able to really make sure that patient experiences the practice and their entire experience with the provider, everyone they contact with, at an optimal level. And we're talking about, all the staff are part of this, right? We need to have the right number of revenue generating staff. Those are your nurses, your nurse practitioners, your physician assistants, physical therapists. All of those staff need to, you need to have the right number. Make sure that they're supporting the physicians and being productive. Clinical support staff, your medical assistants, your technicians, all those people that are providing direct support to the patients, but are not those revenue generating staff. Your front desk folks, your, check-in, check-out, billing, insurance management, all of those are included in this. So these categories you're seeing here is how we kind of group the staff that you have throughout your practices, and having the right people and the right number of people in all these positions are so important for patient satisfaction. Because if your patient sees, say that your staffing level is too high, or let's start with too low. Say your staffing levels are too low and you have people there. What's the first thing that happens when you don't have enough staff from a patient perspective? What are they going to experience? Frustration, wait times. You're there to experience staff that are stressed. They have too much to do and they're trying to just get people, and they're not going to take that extra time to listen and to understand. And you're not going to be able to have an efficient workflow because, it's slower. You don't have enough capacity and your efficiency is just going to be depleted a little bit. So low staffing, it's really easy to see. Let's flip the coin. What happens if you have too many staff working in a certain area? I heard some, I couldn't quite. Chaos. I see this as people tripping over each other, right? You have too many people trying to do the same job, or for your patients, it's like, I have to go see you for this piece, and then I'm going to go over here to see you, and then I'm going to see you, and then maybe I'll go see my physician, right? So, that can really have an impact. Whereas, can we reduce the number of staff to the more optimal level and be able to say, I'm going to walk you through everything you need to know, and then you're going to go see your physician, right? So, there is a balance there. It's really important to focus on that. And satisfaction surveys can be your indicator in terms of where you are, right? So that's going to be things like, were you able to get an appointment when you needed it? How was your check-in, check-out experience? Those kind of questions, that if you get low scores in those areas, you can say, there's something off here. Maybe I need to talk more with my staff to understand what they're doing, what those workflows are, and find those areas for improvement. So yes, you can sense that to some extent on a day-to-day basis and kind of check in with people to see how stressed your staff are. But you also need to hear from the patients to see if they are experiencing that, because they might pick up on things sooner than you're able to from your seats as practice administrators. So now let's talk a little bit about provider compensation and overhead. So, again, this is an optimal level conversation. Physicians are always focusing on reducing overhead, right? How many of you have had a physician walk into your office and say, my overhead's too high, we need to cut it? Yeah, that's not an uncommon thing, right? So, what happens though when you cut your overhead, right? So the first thing to just cut overhead, people say, oh, we have too many staff. you need to, even we talked about having data in other areas for this, but if you have patient satisfaction survey data that says, their satisfaction scores are low and your physician's saying we need to cut staff, say we can't because there's something going on. We need to understand why these satisfaction surveys are low before we make any changes in terms of staff. Is it because we have too many people and they're tripping over each other, or is it too few people and it's just not efficient? So let those patient satisfaction survey scores really guide you to areas that we can improve. So in addition to benchmarking your overhead to other practices, how can we hear that patient experience and have that feed into what we're doing with your decision making in the practice, and showing providers then that they have then multiple ways to say, I'm sensing that our overhead is too high because I'm feeling it in my paycheck and my compensation, but really let's look at where we are in comparison to others, and let's see if our patients are having a good experience, and just gives you an additional source of data to provide back to the physicians in that compensation. And I think they will then in the compensation and overhead discussions, and then I think they will start asking for that. It's like, is this an opportunity for us to improve something so we can find those areas to cut and reduce? And obviously overhead is more than just staff, right? So it's like, oh, do we really need, it's probably your EMRs, your practice management systems. We need to cut overhead. You just said we can't cut staff because then we have too few staff. What about we get rid of this thing? Well, wait a minute. I need to have the system in order to check people in, to, EMR is your medical record. We could look for a new EMR, but then that has opportunity costs, right? And there's transition process. So really making sure they understand and that you're constantly looking at those things. So our patients are saying, my check-in experience was just terrible, or I called for an appointment and wasn't able to get it. So is that a staffing issue, or is that something with the technology? Was the technology a barrier to facilitating that patient experience? So again, there's opportunities to say, the satisfaction survey might be a starting point to say which of those domains that were included in the satisfaction survey are being rated low, where are the pain points, and then let's go look at some other benchmarks, other areas, how we compare and see if we can really get at where the change needs to happen. So all of this is quality improvement, right? Really being able to have the right data to inform decisions so that we're not making reactionary decisions on anything. We're really looking at that information. So, and I know it's hard to find the optimal rate. Sometime we're going to really say here, we're going to say benchmark, orthopedic practices should have overhead levels at this optimal range. I think that's the ideal thing to have. I think we have some trends and things like that. That's something that we really need to work on defining somehow, whether it's coming naturally from the data or it's a conversation of these are what our best practices. They tend to be within this range, right? That's really what we're looking at, because it's not as easy as, more compensation good, low compensation bad. It's got to be at this range. And what does that mean? And how does it vary when you go from different number of physicians or different practice sizes, or you have different specialties represented? All right. So I made some connections for you. What else can you see in terms of integrating this operational data in the satisfaction survey data you're getting back? A lot of you are already collecting satisfaction survey data. So what connections have you been able to make by having access both to that satisfaction survey data and this operational data? Anybody want to offer up an example? Did I cover it all? Anyone? Okay, did I hit the highlights maybe? Okay. Keep thinking, we're going to keep checking in. Do you see any opportunities here? Something that sparked based on what I said that maybe I do need to integrate this, or challenges to doing this in your current process? Back there.
I'm not sure if this is what you're looking for, but on the technology side of it, we realized that we're a high volume practice and that we were having trouble getting the phones answered. Mm-hmm. So we decided to move to a call center model, which has its ups and downs. But we realized quickly that we could have some assistance with the volume, and we took care of that almost immediately. Of course, it was costly, and so now we're in the process of tweaking the service side of that because, answering the phone and making an appointment is, not a one-size-fits-all prospect, and so it's involving a lot of training, guided workflows, et cetera. But I think that's an example of a cost that was kind of worth it for us because, getting patients in the door is the first step.
Absolutely.
And so now we're working on the quality side of that.
Yeah, absolutely. Yeah, so the investment in something like that improves patient satisfaction was totally worth it for you, even though it's like, oh, I have to spend money on this thing. Yeah, and it's a work in progress. Yeah, because that impacts everything, right? Your workflows have to be updated, the way you communicate to the patients. It's definitely, it's an evolution in time. Anytime you make a decision to add a new technology or change technology, it's a hard thing to kind of go all the way through and plan for. But that's a great example. Any other thoughts? All right. I'll turn it over to Brad. We're going to keep asking you for your connections. So as Brad's talking through this, think about how if you have all this data in one place, what connections are we going to be able to make? Because I know that we didn't get everything in our presentation. So tell us what we missed.
Okay, so I get to talk about patient-reported outcomes and connecting patient satisfaction. So what we know is better outcomes leads to higher satisfactions. Every patient wants to get back to the functional status they had pre-injury or pre-osteoarthritis, whatever the initial trigger for the reason for coming to see you was. They want to get back to the way they were feeling before that. So, it's easy to say that obviously they get treated, have a good outcome, they'll be satisfied. That's generally the case. Now, I think a lot of what Vicki was talking about, if you focus on scheduling an appointment, things like that doesn't go well. No matter the outcome, they're still going to be upset. I go into the Apple store, I see a bunch of geniuses standing around, not really doing anything, but here I am waiting 30 minutes for an appointment. Even if I get my phone fixed, I'm still going to be mad. It's, because I had to spend 30 minutes waiting for them to talk to me, even though, there were plenty of people that could have helped me. So I think that there's a lot to be said for that. But measuring satisfaction and outcomes can really help you improve sort of those clinical workflows, improving your interactions with patients, improve the market position, and increasing your practice's social reputation. So when we were talking about earlier, sort of the Google and Yelp reviews that are out there, those are typically the most annoyed patients, and I really do think that, yes, if you are reaching them before they actually feel the need to go to Google or Yelp to feel heard, because, that's ultimately what we all want as human beings, is to feel heard. And I think that there aren't many opportunities to have sort of that one-on-one interaction in healthcare with someone who can really make a difference in the care that they receive. Because, you go to the physician and, the entire time the physician is with you, they have to sit there typing into their computer. If you don't have a medical assistant that's assisting them with that. I know that's the case with my physician. I'm used to it. It doesn't seem to bother me, but you get older patients who aren't really dealing with a lot of that. They're used to dealing with that. They see that and they view that as poor communication skills. Doesn't matter if you tell them they have to do that. Medicare requires them to do it. They view that and that leads to a lower satisfaction for them. So, as we said, social reputation, anyone with a computer now, an internet connection can damage your practice's reputation on Google, Yelp, and other platforms. So really the key is to start fighting back with real data from your patients, utilizing this kind of data in your marketing. So to be able to say, look, we had really high satisfaction, really high outcomes. I think that's going to be important going forward. So what we're talking about is trying to gain a window into the entire patient experience, from scheduling their appointment to a year following their surgical procedures. So many of those outcome surveys have set schedules that they send them on. If you're already doing those, you know all about that. But I think the COOS and the HOOS are, 7 days prior to surgery, 3 months after, 6 months after, and a year after. So that's what we're really trying to say is, up to when they schedule the appointment, all the way up to that year at post-acute. you're able to sort of gain a window into how the patient's doing, what they're feeling, what they're thinking, all kinds of information that can really help you improve sort of their experience for that entire year. So looking at appointment scheduling, the reception process, clinical and patient support, provider visits, surgery, post-operative visits, and ultimately recovery. So I think this was really good when we were talking about getting an insight into a patient's outcomes. So looking at them 6 months, doing an x-ray to see just exactly why they're not having the outcomes that we want them to do, and finding out if they didn't have enough physical therapy. I think that's something that can really that really touches on both of these, patient satisfaction and the outcomes, because if they can't move around, they're not going to be as satisfied as they could if they had had the kind of physical therapy they needed and get back to that functional status they were expecting. So improving patient outcomes. What we're looking at are global functioning and functional outcomes. Think global measures like the PROMIS, and then functional status assessments like the KOOS, DASH, and others. By uniting satisfaction and quality in this manner, you can view how those satisfaction and outcomes are related. So how poor satisfaction can lead to poor outcomes. The patient comes in, they're upset, they feel they didn't get the respect they needed from the provider. Are they going to do what the provider tells them to get back to that functional status? Me, I'm stubborn. I don't like how a physician treats me. I might not do what he tells me to. If I were a smoker, I might not stop smoking when he tells me to. And all those lead to poor outcomes. If they feel like they've been respected by the provider or the provider has listened to them, then they might be more willing to do what the provider tells them to do in order to achieve that functional status. So these are all tied together. And what we've seen is that while satisfaction is just one variable that impacts patients' outcomes, the doctor-patient relationship has been shown to influence those outcomes, or has been shown to have an effect on clinical outcomes. It's not causal. We can't state causality based on those reports, but there's definitely a correlation between the two. So connecting patient satisfaction and outcomes while giving you insight into a patient's path to recovery and workflows. It also gives you an opportunity to innovate with your compensation models. I don't know how many of your clinicians would readily agree to this, but it is an option for you. Many compensation models now are based on productivity, so how many surgeries the physician is performing, how many patients are seen. But just imagine incentivizing quality care in your compensation models for clinicians who may exceed your organization's quality goals. Incorporating those outcomes into your compensation models better aligns your packages with the switch to value-based care and pay for performance, and can begin to sort of wean clinicians off of the traditional fee-for-service. As long as fee-for-service is around, the switch to value-based care is just going to be much more painful for the clinician because they're going to see their reimbursements chopped by Medicare or by private payers because they're not meeting those quality expectations. Okay, and then connecting satisfaction and outcomes. So what other connections can you see out there between satisfaction and outcomes?
Or the other thing I was just like, do you want to react to what he just said? Can you imagine a scenario in which our compensation models are based on outcomes and quality?
I feel like I don't need this, but okay. So in my organization, we have an incentive package for our providers where a portion of their salary is withheld, and then there are metrics they need to meet that are based on outcomes, and depending on how close they are, or they get a certain percentage of each one, which will hopefully equate to 100% of the incentive. So we've been using that, and I think that it's made them much more aware of what they're doing and of the outcomes and monitoring those things. We also have a lead physician or a champion physician who has been meeting with our physicians who have lower patient satisfaction scores, and he is trying to work with them on their simple things like communication and not standing in the exam room with your hand on the doorknob, and maybe sitting down and making like an eye-to-eye, heart-to-heart type of connection with the patients. And we've seen a tremendous improvement in our patient satisfaction scores just utilizing that one thing. So I don't know if that's related, but I just wanted to.
That's definitely related, yeah.
No, that's fantastic, and I love to hear that we're not as innovative as we thought we might be. That this is something that's already being implemented in some practices, at least. Because like I said, the longer fee-for-service sticks around, the harder it is to get them off of it. And that we're just entering an environment where fee-for-service, we can see the end of that. Medicare has already made it very clear that its time is limited. So it's, if you want to make the transition less painful, getting to a compensation model similar to something like that, or is something that it could probably help that transition, farther along. Anything else to add?
Can I just ask how many physicians do you have? How many of them are others?
We're actually hospital owned, so my setup is a little bit different, but we have 27 in our orthopedic practice, and then we have several podiatry practices, and we incorporate rheumatology into our musculoskeletal. So we have an osteoporosis clinic, so it's a little different because we're hospital based.
Okay, and yeah, just to summarize part of that, she was just curious about how many physicians are included in the practice, and you said you're a hospital-based practice. So, but then the challenge, if you're not hospital-based, how do you translate that to a private practice, right? There's still opportunities to learn. It's like, how can we do that? If you have a hospital system setting, that's really, you can leverage some things, but how do we translate that back to private practices? It's awesome.
So for the past 12 years, I've actually been a representative of the downstream provider. I've worked in long-term care until 2 weeks ago. So welcome to me and figuring out what we're talking about. But I would say kind of why I'm in the position I'm in now in an integrated health system, and that's where the orthopedics providers are. So many of these data analytics happened on the other side, trying to identify what were some of the key problems that they were having. And it really came to the identifier that not only the hospital, but the long-term care side, in this case, the subacute rehab, could no longer work in silos. And so all of these things that you're talking about were things that we worked on, and we used hip fractures, for instance, as one of those areas that was a problem, and that started as a quality identifier, and it was affecting reimbursement, and they were in a bundle, and you could just make so many connections from this. And as the downstream provider, a lot of, I guess, what some of the connections of this is important is to improve market share, to improve patient experience, to improve outcomes requires a lot more connections, whether you're private or whether you're part of an integrated health system, thinking about how all these things kind of work together. And I think working in the long-term care side for so long, super tight margin business, this has been something we've been preaching for years just to survive. And it's getting to that point now, I think, for organizations that maybe have been revenue rich, but now it's getting tighter and tighter and harder still to do it in an efficient way to meet all these criteria and outcomes.
Yeah.
Absolutely. Other connections that we may have missed that you see or that you might be curious about?
Okay. Any challenges to implementing some of these or opportunities that you may have seen? Or just anything you don't agree with what we said?
Yeah, you can disagree. Yeah, this is not going to happen. That's weird. You guys aren't being realistic.
I think the younger surgeons coming out are more adept and can be molded a little bit more because that's what's kind of being preached in the academic world. The older guys, I don't think there's a lot of hope other than retirement. And yes, there's a difference between hospital based and owner shareholder based. It's a lot of these things are nice, but unfortunately is that a lot of physicians that are independent, before they spend the money, they want to see the ROI, and you just can't do that. And so you're constantly ping-ponging back and forth until you mandate it like Medicare does.
Yeah.
They don't do anything. And it's that intangible that they can't see is, why do I want to spend $30,000 on this project when, I don't know, and it's going to benefit those guys more than it's going to benefit me.
Yeah.
So why should I have to pay my 1/8 of that cost? I should pay 1/32 of that cost.
Yeah.
So, you end up with all the arguments of those kinds of things that go on. But I think it's just time that's going to just move these things to where you can get the total.
Yeah, I think that's a very valid point. As in an independent practice, with a clinician who owns a part of the actual practice, why would they want to pay, like you said, 1/8 of a nurse navigator salary for all this stuff, if that's what's required to get this off the ground, so to speak. And we're not saying that's what's required, but we know that's what somebody had mentioned. They have a nurse navigator who handles a lot of this stuff for them, and they've seen success with it. You're right, and that eats into their overhead. So why would they pay for that, so to speak? And I don't really have a good answer to it. And I don't think any of us do, otherwise we wouldn't be here. But,
yeah, but I think you make a good point on the other end, supporting the ones that are just coming out of the residencies and schools that might be eager for this data. Is how can we teach each other, right? So, or they start to expect that in their compensation models, in their plan, as the older ones that might be more resistant retire, right? So that we can have that transition point. And the question for us is, how do we accelerate that process, right? How could we provide the data in a way that's like, we have to have this, we have to use it, because we believe this is really what's going to improve orthopedics.
Yeah. Oh, back there.
I want to say, coming from both sides, I've done both private practice and I've done employed physicians in a large health system. And one of the things that I see that we miss the mark on is the providing the information to the physicians beforehand. And I look back at where I was most successful, and it was that we were always proactive. So it goes back to when it was called PQRI. We were ahead of the game because we had somebody that was always out there looking ahead and bringing back the information. And we would sit down with the physicians and we would say, okay, here's the impact. And when you put a dollar figure to that impact, then you got their attention. But it's always being proactive versus reactive. And the organization that I've, gotten into right now, it's teaching them. And it's also having strong leadership in your physicians that are going to be your physician champions, that are going to push that through. But it's also bringing that, physician champion, that information ahead of time and saying, look, here's what's the impact that's going to happen here. And that's what we need to do. And that's what we're trying to change to. It's not an easy change. But again, if you're, proactive and you can show them the dollar figures behind it. I mean, right now we have physicians that won't do their charts. So I said, well, here's how we're going to do that. We're going to sit down with them and we're going to put a dollar figure. And we're going to say, this is how much you have sitting waiting that's getting close to timely filing that you're not going to get paid on. I can put down, we've already put down you have 150 charts that are outstanding. That means nothing to them. But when you put a dollar figure to it, then you change their mind very quickly. But I'll report how, next time maybe I can report how that is working for us.
Right. Yeah, please do. All right.
Okay. So quality and outcomes now. When talking about quality, we're looking at the transformation of reimbursements from fee-for-service to value-based care, where clinicians are reimbursing the value of care provided rather than the volume of services provided. We've already talked about that a little bit, but just want you all to know it's coming. You guys already know, but the more we can hammer home that point, the better. This transition is really being driven by the Medicare program and Congress. Blame them. 535 people have blame to go around to them. So this was created when we got rid of the sustainable growth rate. We were very excited. And then we see the MIPS program come, and, you know, it's almost like we kind of wish we'd stayed with the devil we knew rather than with the devil we didn't. But you know, it happened. It's here now. And other payers have jumped into the fray. They've seen an opportunity to cut costs. You know, I think a lot of people say that, well, MIPS is all about just cutting the costs to the Medicare program. And that's part of it. You know, Medicare is very cost sensitive. If you haven't seen the latest projections, the Part A trust fund, the hospital insurance trust fund, is projected to run out of money by 2026, I believe. So it's coming. You know, and running a single payer system for those 65 years of age and older isn't an easy task. And it's certainly not easy when Congress is constantly raiding the fund for its own spending priorities. But that's just something to be said. It is very cost conscious. But it's also an effort to try and increase the quality of care provided to Medicare beneficiaries. That was the goal when the Medicare program was signed into law in 1965 by President Johnson, and it remains the goal today. This transformation, though, is evident through the establishment of the MIPS program, advanced alternative payment models, and other outcomes data collection for insurers and government payers. So is anybody's workers' compensation program starting to do some of this? No. Okay. I would expect to see in the next couple of years as some of these workers' compensation programs move from a fee schedule over to something like this as well. If you don't like that, you can always be active at your state legislature, run for office, do whatever you can to get in there and stop it. But barring any of that, I would expect to see that. So how many of you are directly responsible for negotiating with insurers, whether you're part of their network or not? Okay, quite a few of you. So just think what it would be like if you had the data showing the value that you bring to that network. Would an insurer be more likely to treat your organization as a priority? Would they be more likely to include you within your network more at your terms rather than solely on their terms? What about direct contracting with patients or large employers? Direct contracting models for primary care have just been announced by the Centers for Medicare and Medicaid Innovation. I don't really know that that's really translatable over to orthopedics just yet. But it's out there now. It certainly could be. And we do know that some mandatory demonstration models that will affect orthopedics are coming out. We don't know exactly what those are just yet. But I would expect to see it. STARC compliance. So not basing your pricing strategy on volume of services, basing the data related to outcomes and overall value. You know, AAOE, along with other organizations, have been working really hard to try and get some changes to the STARC law, as well as the anti-kickback statute made that would make it more amenable to the value-based care transition, and even providing an exemption for those participating in demonstration models to set prices based on the value of the services that they provide, not taking into consideration the volume of it. But those are just some examples of sort of how these can help with some negotiations and contracts for you. Quality measures tied to musculoskeletal care insights into what patients can expect. You can identify improvement activities that are really meaningful for your patients, able to get improvement activities points for collecting and utilizing patient satisfaction survey data for improvement processes. So these are I don't know how many improvement activities measures there are, but several that are related to exactly this, doing patient satisfaction, patient-reported outcome surveys, and utilizing that data for practice improvement. So that's just one way in which this quality aspect ties into satisfaction and outcomes. Okay, so MIPS measures are tied to outcomes. Your functional improvement measures, there are several in the list of measures that we support, and then your readmission rates. Those are all part of that sort of quality aspect of care. For those of you in hospital organizations, hospitals are part of that Medicare value-based purchasing program. They're also part of that readmission program, reducing readmissions. So those will be very important. You know, if you're part of a hospital outpatient center, you might have certain protocols in place to reduce those particular admissions that you have to take part in. If you're an independent provider with admission rights to a particular hospital, you might have something similar that the hospital requires you to take part in order to reduce unnecessary or needless readmissions. MIPS measures requiring screening, so preventing complications tied to outcomes and satisfactions. There are several surveys that we won't really talk about too much today because they're not ready in Empower, but there are several surveys that are in there, such as the opioid resource tool, as well as I can never remember what the acronym stands for, but it's a depression measure that are tied to musculoskeletal care. So obviously opioids, it's a big crisis facing the United States right now. Certain states in particular, Indiana, where we live, is one of them. Kentucky is another one. I had to get a hepatitis A shot just to go home to visit my parents because they were in the midst of an outbreak in Louisville. Not something you'd think you'd have to do. Actually, when I went to get it, she was like, "Are you going out of the country?" No. It's just some people made some really bad decisions. So it's, you know, I didn't want to get it, but, so it's something that should be taken very seriously, and it's something that we're pleased to be able to offer through Empower. So let's talk. What other connections can you think of about tying quality to satisfaction and outcomes?
Your juice is flowing here or there?
Okay. Any challenges or opportunities, or again, anything you disagreed with what I said on?
Or maybe we can present the dashboard and see
Okay.
if that triggers.
So this is building an orthopedic dashboard. You know, this is not what, so that's one of the things about Empower is that we're working on creating this dashboard for orthopedic practice executives to utilize to sort of see where you are in relation to other practices. You have your reports, but then you've got just a dashboard that lets you see some of those key components of your practice. But you got your business requirements, your productivity, your compensation, patient satisfaction, outcomes, and quality. These are some of the key components that we've just talked about that will be part of that dashboard. And this is not what the dashboard will ultimately look like, but it is an example of sort of how we would put this data together, maybe possibly display it, and see if you had any comments on it, concerns.
Yeah, so imagine that we actually had a dashboard that you participated in all aspects of AAOE Empower. It's not required that you do, but say that you collecting the satisfaction surveys, collecting outcomes, collecting quality measures, participating in the benchmarking survey, and we said to you, here's your dashboard. What are the metrics that should be on that dashboard? Are these the right ones, or did we miss some? I would love to hear, it would be great if your dashboard would include X. That's the feedback we're looking for here, because this is, again, it's a work in progress, and some of the, we're giving you a mock-up of what this could be, because we need to get to the point we have the data on which to base this. But where are we going? What are the metrics that are going to be truly powerful, meaningful for you to be looking at on a regular basis? So just reflect on this, and then tell us, is this right? Did we miss something obvious? Or do you have wonderings about other things to be included in there?
Vicki knows that I'm all about the details. So what if there was a line in each of the blocks for variance? Because that immediately catches your eye about where you're off. Mm-hmm. And then my question would be is how frequently would this be updated?
Yeah, that might be a question too. How frequently would it need to be updated? Some of these things are moving on a daily basis. Other things are more static, right? So it might be that individual blocks or pieces of this need to be updated more often than others.
I'm curious how much you can drill down, like overhead by revenue is great, but could I get, billing department expense, per FTE per department? So how much we can drill down so I can say, okay, front office, if I reduce 1 FTE and have 3 check-in kiosks, how is that going to affect revenue by that expense and revenue by that department?
Yeah, so that's an ongoing conversation. I'm looking at 2 benchmarking council members right next to you there saying that's an ongoing conversation, right? You can drill down a little bit to some of that information, but we don't ask about all the detail, right? Because if we asked about all the detail, nobody would participate in the survey because we'd just be asking too much. So there is a balance there in terms of what you can drill down into. And I think as you look at this dashboard, we have to be aware of that. Is like, in order for it to be valuable, how deep do we have to go? And then how do we get all the participants in the process to understand that the reason that we're asking for that additional information is because we need the additional detail, because it to truly be valuable for your practices, it need to be very granular. And are there other ways to capture that information? You gave examples, operational metrics. How do we get that information that doesn't require you to input data into a survey, that we're just getting that from your systems or whatever?
And furthermore, and then also benefits expense. Like how does my group that just offers health insurance compare to other benefits that other groups offer? And so being able to maybe add that into the operational is, what kind of benefits do you offer your employees, and then somehow can you relate that to employee wellness, and does that improve revenue? It's just a rabbit hole. So
yeah, but those are really good questions. And then that's something else. I know you get a lot of emails from AAOE. We send you surveys often to ask you for additional information. And it's, there's reasons for that. Sometimes, like a monthly survey, say, tell us what your benefit practice looks like, your benefits package looks like, and how does that compare to others, so that we can do these advanced insights. It's like somebody earlier mentioned survey fatigue, right? We're asking our patients for a lot of information. We're asking for a lot of data, which requires a lot of information too. So how do we walk that line to make sure we're getting the right information that's available to you when you need it?
And call center came up earlier today, but I've been going back and forth and actually been doing a lot of revising in the call center. But what I'm finding is in the healthcare industry, it's not very easy to find call center data and metrics to benchmark our performance. And every time volume is down, it always comes back to the fact that the appointment scheduling department isn't doing their job correctly. But constantly trying to communicate with the physicians that, we have 1,000 calls that came in today, but only 20% or 26% of them were actually appointments. 20% of them were cancellations, and we're now collecting better data on that, but I have no way of knowing whether or not we're doing good or not doing good, because there's not medical call center data available to us. So call center would be an area that I would definitely like to see more information about.
Okay, we're creating the wish list, at least for the benchmarking survey. Love it.
Vicki, we had a question over here too.
I think he's going to... We'll get her question while you're doing that.
I don't think I could take this off.
Yeah, I'll be right there.
Could you do a survey on what we want in a bench? Could you do a survey on it and then ask us? I mean, it doesn't have to be long, but maybe have just do a survey asking what everyone wants.
Absolutely. We could even put one together, and you could start at conference to fill it out. Okay, I'm going to grab this question over here, and then I'll come back to you. Where was it, Red?
Right there.
Right there. Okay.
Something that you're already asking is like how big our group size and how many physicians. Can you break down the operational by that, and if they're like physician-owned practices versus a hospital-based, or like a 5-physician practice versus a 20-physician practice? Because operational can obviously vary greatly. So to know that you're at the national level but we only have so many physicians versus a hospital or whatnot.
Yeah, absolutely. And you even talked about it not just being by the number of physicians. Several times it's, how many providers do we have? You could say I have this many physicians and I have this many physician assistants and nurse practitioners, broadening that definition of practice size a little bit, or it's by revenue, right? Some of our practice sizes are defined in other ways. So yes, you're able to dig into the operational metrics right now that way, and I anticipate that'll be the same way for the satisfaction and the outcomes, because that's important for us to be able to compare apples to apples, right? We can't look at a 5-physician practice and expect it to correlate directly to either a hospital-based setting or a practice with, 100 providers in it. So,
I wouldn't want to go by revenue itself, only because maybe we're a high generating revenue and we have low amount of physicians.
Right.
So I would want to look at more practice based of how many physicians or providers you have, not by revenue.
Right. Absolutely. Good point. All right. I told somebody to come back over here.
So I think it's wonderful that you have patient satisfaction, but what is the thought on team member engagement and team member satisfaction? Because I think that's a key driver to patient satisfaction, and also the staff to provider ratio, and how that plays into team member satisfaction as well.
Okay, great. Yeah. Capturing that idea for sure. Yeah, and come talk to us after the session about employee satisfaction surveys. That's one of the next things that I think we're going to be able to help you with. It's just a matter of identifying that survey, right? What do we want to do? But you're absolutely right. How engaged are our staff? Or do they believe in what we're trying to do, right? That really helps this whole process when we talk about workflows, collecting data, doing quality improvement, whatever it might be. Other thoughts, things we're missing, things you like about this, questions? Because I'm blinded.
Yeah, I would say one thing that we're looking at too is the survey on patient safety. So anybody else has done this through AHRQ. We're looking at, although they're really terrible about getting back to us about what we need to do to be a certified vendor for that. But we're looking at doing that. It's an employee survey. How many of you have actually participated in that survey before? Nobody. Okay. Fantastic. Is that something that you'd be interested in seeing? Just how safe are your patients in your practice compared to others? Or is that something that we shouldn't even bother with? Yes, no, maybe? The survey itself asks questions like, are patients left by themselves for long periods of time? Are they left around sharp instruments? So, you have needles just sitting around. I don't know what practice would, but, it's things like that. So just how easy is it for a patient to harm themselves within the practice? And that's gauging just how safe the employees feel that patients are. And that's one of those surveys that qualifies for both an improvement activity under the MIPS program, although it's every 4 years. You can't do it every year. But it is also something that could potentially be benchmarked on in the future.
Yeah. Feel free to continue to think about this and talk with us throughout the conference about what that dashboard, that ideal dashboard might look like. And I think it is something we need to revisit. And absolutely we can ask you questions about what would you like to see both from the operational side, how would you like to be able to filter the data, how, as we introduce satisfaction reports or outcome reports, so what additional filters do we need? I think those are all great next steps for the process.
Yeah. So we covered this. There you go.
All right. So how are we collecting all this information? We talked about the vision, trying to get to connections and try to really say, why do we think it's important to have all of this in one thing that we're called AAOE Empower? So I think you get the connections, you got the vision, right, of what if we have all this piece. So let's tell you a little bit about AAOE Empower and some things about how you get started, and then we can continue the conversation through the rest of the conference and beyond. So obviously AAOE Empower is bringing all of these data points under one umbrella, right? So we're going to make these connections. You have one place to do it. We're really excited that we're able to develop this. We really think it's a benefit to orthopedic practices. We think it's a benefit for AAOE members, and we really want to make it your single source of data, right? Bringing all these things together. So when we're talking about AAOE Empower, we're talking about Power Surveys. Power Surveys is the vehicle that we're using to send surveys to patients, to employees. It's the same process that we're using to send the benchmarking survey to you. Power Insights are the reports, the dashboard that we just talked about, individual benchmarking reports related to outcomes and satisfaction. That's that piece of this. And we'll talk about, you don't have to use AAOE Power to send surveys to your patients. If you already have a way to get that data, you still want the insights, the reports, there's ways to do that. So it doesn't mean that you have to use that survey piece. We have the AAOE Registry, which is the ability to capture your quality data, whether you're going to report it through us as a registry for MIPS reporting, or you have another vehicle again to report for MIPS quality data here that we can create and use in benchmarking. That's the vision, is that we have this one source of data that's kind of agnostic to vendor. So if you're using other vendors for these purposes, that doesn't mean your data isn't valuable for this process. So providing a platform that is very valuable to you and at a price that everybody can afford, right? So we try to balance that line. So we obviously pay for our technology, but we try not to make it inaccessible to anyone. So this is the conversations and the vision for AAOE Empower. So let's talk a little bit about this. So Power Surveys, manage all your surveys, right? We're talking about employee satisfaction, patient reported outcomes. We have the ability to help you set up those surveys. You can customize it to your practice. You can, send via email or text message. So if you have a patient population that's going to be more likely to complete a survey on their phone than they would if they get it on their email, so we can send it via text message. I think that's another transition point. Right now, a lot of practices are just sending via email because that's the data they have. But now it's like, maybe we could start capturing cell phone numbers so we can do text message. So I think that'll transition over the next few years. Somebody mentioned earlier about completing the outcome surveys while they're at your practice for a follow-up visit, right? Somebody's coming in, they're due for the survey. I'm going to have a survey preloaded on the app, and they'll be able to pull it up, and it informs the process. As soon as the survey by any of these means is completed, then it's populated into AAOE Empower for reporting purposes. You can personalize those messages. You can personalize the survey itself with your logo. A lot of things we're doing to improve the response rates to all of these surveys, right? So if it looks like it's coming from your practice, has your logo coming from your email domain, patients are going to be more likely to complete that survey, open that link, right? We get spam messages all the time. We're trying to really make it something that, you can get good responses, because maybe you've educated patients on the fact that you will be sending a survey ahead of time, and then they get the survey from your practice that has your logo that looks very familiar, then they're going to be more likely to increase that. And we have a couple ways. You can do all this yourself. We have set it up so it can be self-service. You can do it at your own pace, or you're like, I don't have time for that. It's like, we don't have time to do a survey. You don't have time for that. Call us. We will walk through the process, ask you a few questions, get it set up and started. You just review information. So you don't have to feel like you have to do all this on your own. We will work with you and for you to make sure the pieces are set up. All the surveys have default schedules defined based on the type of survey it is, and by the authors of the survey. So, Brad talked about the baseline. You need to collect information before that surgery date, and then that outcomes at whatever intervals make sense for that tool. Pretty standard to be, baseline 90 days, 6 months, and a year. But you can modify that to some extent. If you deviate too much from those fixed ones, that affects benchmarking. But you say you have a physician that has a research interest for a specific outcome survey, and they say, oh, well, I want to do one more administration. We can add that. Or it's like, well, this is just too many surveys. I need to drop one of these. Maybe I want to drop the 90-day, or I want to drop the 1 year. You can modify some of those points. There are reminders built into the system, so, a lot of people don't fill out the survey. It might take up me 3 times before I'm actually going to click the link and complete the survey. So there's reminders that you can schedule for whatever frequency you think is appropriate, again, for your population. The biggest, discussion we've been having lately with practices is how do you know who to send the survey to and when, right? So there's a couple different ways. You can upload your patient scheduling data into the system, which obviously some of you are going, that takes time. Somebody's going to have to do that process. We can also talk with you about connecting to your practice management system, your EMR, whatever system stores that scheduling information, so that we know patients coming in automatically through that HL7 feed. We'll work with you to say what codes will indicate that this survey should be sent, whether it's a diagnosis code, a procedure code, whatever information is there. We'll define that with you, and then we will send surveys out based on that information. So I'm trying to take the manual step out of that process as much as possible. So again, just to note that the benchmarking survey is based on the same platform. The ability to have, power surveys here based in the AAOE Empower, continue improvement in the surveys. So if you haven't started your survey, if you completed it last year, you will go in, you have the opportunity to pull in last year's data. So some of those text-based things, you don't have to add all your providers again. They're already there for you. So as you're considering whether to do it again to do it for the first time this year, first year might be a little harder. Take a little bit longer because you're getting used to what reports you need, get used to how the chart of accounts aligns with ours. You have to enter additional information, but no, some of this will be there for you next year. It'll pull over. You'll have all these procedures and reports identified, and you'll know the process. So it does get easier the more you do it. So keep that in mind. And a lot of opportunities to customize your survey. So, what lines of service do you have in your practice? What sections do you want to complete? Somebody asked whether you're required to complete the entire survey. Absolutely, you don't have to complete everything. Some things I know I'm not going to have time. I'm going to give you my square footage information, or I'm not going to give you all my payer mix. I just don't have time for that, but I really want this compensation data benchmarked. I want my revenue and expenses benchmarked. Complete those sections and tell us what you want. Again, we have a lot of ways that we're managing the data. So again, we can do this with you in terms of service, data services team, Brad, myself, our data analyst, Daniel, can help you through the process. We're called managers all the way through it. So you can go in and log in and look at your patients. You can make sure your practice is set up. You have all your providers added, your employees added. You can do all of this on your own time, or you can say, hey, I have a list of my employees. Can you just put them in? Yes, we will help you with that. You have ways to manage your patients. So if you want to send a certain survey to patients or you want to see the status of their surveys, you can go to your survey list and just filter on a variety of things to pull up the right surveys, or you can send surveys separate survey directly to those patients. So again, we can talk more about that. Some of you ask all the time about permissions. It's like you don't have to give everybody in your practice access to the entire database. You could say, I just want to get started and I'm going to do it, but I really need somebody to come upload some data for me. And you can give them access just for that upload piece if you don't want them to see some of the reports. So it is a very permissions-driven process so that we can set it up so you have access based on your participation, but also on the roles of employees within your practice. And I mentioned this several times. Contact us for help. We're data services at AAOE to help you through the process. Okay, I'm going to click through this. So questions about the survey process that you curious about right now?
You said it's customizable, but is it basically customizable in the sense you have preset questions that we can select which questions we want to use? And if that's not correct, I guess my question would be let's use satisfaction for an example, how you ask a question in my organization about that versus how someone else asked that question now makes that data not necessarily consistent for outcome use. So how is the surveys balancing that, I guess.
Yeah. So, for satisfaction, let's talk about that. So, we mentioned the Net Promoter Scores and we have the full CG caps, or we have taken this core satisfaction surveys out of the caps. The wording and the response options for those wouldn't change. So if you have, a different question you like, you could add those to the survey so you're still capturing that data, but we wouldn't benchmark it against it, right? So if you have a question wording or response options that vary from what we already have in the system, we're not going to be able to benchmark and that was hard, and that's going to remain hard for satisfaction surveys, is that even though if you look across the survey that you're using, I bet it overlaps with some of the content areas that's reflected in the CG caps, but if it's not worded exactly the same or those response options aren't the same, it's very hard to benchmark across. So when we say customizes, maybe you add the 2 Net Promoter Scores to a survey that you already use and love, and we just benchmark on those Net Promoter Surveys questions, but you can still use our system to get those surveys out, and then we'll provide the data back to you. It just wouldn't be benchmarked unless we say everybody else, hey, this is a survey that some practices are using. Do you want to use this version? And then we can benchmark later on. So yeah, obviously you can only benchmark when the questions are the same and then for outcome measures, you can't customize those, right? Because those are more standardized tools. So anytime you add a question or drop a question, you mess up the scoring. So the outcomes piece of that is a whole different animal. But yeah, all the surveys that we're talking about here are set up as starting points, and you can choose which ones to use. You have the ability to send other surveys out. We just have to have time to catch up on the reporting side.
Yeah, and a lot of the customization that we're seeing right now is linked more to customizing those satisfaction surveys by practices with multiple locations. So they find the appeal of being able to benchmark very alluring. So rather than changing the questions, they just say, okay, can we add something in there so that we know what location this patient was seen at? And then, we just have a drop down in there, and the patient can go and select where they visited the clinician at. And then they fill out the standard CAPS and Net Promoter Score survey.
Okay.
How often is this data pushed to us? Is it real time, monthly, quarterly, yearly?
Yeah, so you'll have access to your survey data. You can go in and see the responses both at an average level and at in individual patient levels. Like if you want to see how a patient has responded to a survey, you have the ability to go in and see that. Benchmarks will take some time to accumulate. So at least quarterly, we'll be pushing out updated benchmarks. Depending on the volume, it could be more frequently than that, right? So, right now it's really quarterly. We're just getting to those first reports in AAOE Empower. So, you'll get the first look at benchmarks for those surveys that have the data available. And then at least quarterly is very important to us, more often as there's data to do that. So we have the capacity to push those reports. It's just, yeah. So I think that's the minimum. Monthly would be the ultimate goal. So we'll keep moving in that direction as we understand the process and build it out. Okay. Let's move on. The questions popped up there. We'll save that one. Make sure we get through some of these things. Power Insights. These are the reports. I showed you an example of a benchmarking report from the operational side of things. It'll be the same thing for all the reports in the portal. Multiple levels of results. You have industry benchmarks. We're going to, when you come to the Empower station, we can show you more about what the reports are going to look like in there, and that will be available to you soon, or really immediately after conference. Really, they're there. We're going to push it out during this conference. So, how your survey scores. So to take those outcomes, they have a score involved. How your scores compare to other orthopedic practices, how your scores on individual items compare to others for some of those tools, and then being able to look and capture those patient responses. All those things are so important. I'm going to bring this back up so this is what we're talking about. The filters will change when you're talking about satisfaction outcome scores. In addition to what you see here, it's provider level, it's demographics for patients. You want to make sure you understand are things happening differently for different demographics, different population of patients. So those will be integrated into the reports that you see. Same platform, same look of the reports, same functionality. Ability to filter is so important to what we're doing so that you're making the right comparisons when you have an important decision to make or you need to look across these metrics. This gives you an idea of some of the, ways that you can look at it. You have summaries available for response rates, looking at patient responses so you can follow up, or you also have the ability to export the data so that if you want to go, here are all my patient responses, and you want to be able to do some analysis and incorporate it in what you're doing, you can export it as a CSV file and then integrate it what you're doing at your practice. So that's very powerful to be able to just do those analytics on your own too. So whatever, if you needed something a little deeper or a one-time thing that you need to look at, you have the ability to export that data so that you can use it in your own software. Again, I'll look at some of the things that the reports that you'll have available to you in Power Insights. Want to make a note about data security here. Obviously, I'm asking you to send all your data, right? Your practice data, your patient's data, they're going to be, their scheduling data, that is a lot. It is a process. So, we talk about participating in the benchmarking survey differently than signing up for the AAOE and Power, Power surveys piece of it, because it is a different set of data. There is a participation agreement that you have to sign in order to utilize all those functionalities. It includes a BAA, so it is a longer process. That outlines how we're able to use the data, what your responsibilities are, so that is part of the data security. All our servers are based in the most secure data centers that we have, meet all those standards for the high trust certified data center. We're able to do that through a partnership with our developer who has experience creating these healthcare systems and technology for other services too. So we talked about permissions driven access. All that to say, data security, the security of your data is number one priority for us, and we will continue to make sure that our systems are as secure as possible. If you have any questions about how that's done and want to go a little deeper on that, you can talk to you about how to connect with our developer who is here at conference. So he can talk to you about that data security. If you have questions about the participation agreement, be happy to pull that up and walk through that with you. But we can make sure all your technology questions are answered as well, so you can be very comfortable with how your data is being managed. All right. Questions about insights?
Is this already happening? So you have HL connections,
yes.
So if there's HL7 connections already established with certain software, that would make it easier for us to go to our vendors. So is there a list of different either practice management software companies or EHRs that you guys already have developed these HL7 connections with?
Yeah. You have a list, and some of it's one by one. So we're going through the question about HL7 connections and which vendors in a couple different ways. So some vendors have connected with us formally at the vendor level, and others are like, my vendor isn't interested. Is there a way we can do this? Because if you already have an HL7 connection at your practice, it's often you're able to take that same feed and divert it over to the warehouse. So that has worked at the practice levels for many. So we can talk on a vendor. I'd rather you come and say, does this vendor have that connection? But yes, but regardless of what systems you use, if you as a practice administrator contact your vendor and say, I want you to connect to the data warehouse, that's what's going to prompt those additional conversations. Because right now we're talking more of a handful of connections with those vendors instead of 50, right? We want all of the systems to connect, because to get to the broader vision of what we're trying to do, it needs to be, again, it doesn't matter which pathway you're coming in, we have the source of data. So we're still pushing that envelope, and it's been a little slower than we anticipated. But yes, the first time we do a connection's harder, and then we can build it out. And the ideal is that we connect with the vendors directly and say, you build it one time, it might cost a little more, but then it's going to be available for anybody else, and just turn it on. So the more of you that reach out to your vendors and encourage that connection, the better. So, but let's follow up on where your particular vendors are in this process.
I know we said we don't want to track outcomes just to meet requirements, but selfishly rolling back to that, what does participating in the power give us back as far as meeting the requirements for MIPS, for example, or bundle payments or whatever?
Yeah, and Brad, we'll probably talk about that in a minute, but I'll give you my short version of that too, is, a lot of this is connected, right? So we talked about improvement activities, and based on somebody else's questions, just doing a satisfaction survey, even though we're not a certified vendor for the CAPS for MIPS, doing a satisfaction survey, having quality improvement plan based on that, then it allows you to apply for some of those improvement activities. And since we have that registry component in addition to the satisfaction, it helps you with your documentation that you need to make sure if you ever question whether you're doing that process, right? So you're connecting across those things. Same for the outcome measures. As Brad discussed, there's a lot of quality measures that are based on functional outcomes. So those outcome measures included in a system, you can capture that data and then we can turn it around and report too. So it's just, again, and then it's the ability you already have all that information regardless of what mechanism you're reporting on and using in one platform, and then you can level up what you're getting beyond just those requirements. Questions? All right. You talk about the registry.
Yes. Okay, so being the one standing between you guys and the end of this session, in about 12 minutes, I will try to make this as quick as possible.
Yeah, and I would say, focus on the registry, and we can talk about next steps at Empower if we need to.
So as part of Empower, we have what's known as the AAOE Registry. That is our official name with CMS. So if you're looking at the QCDR Qualified Clinical Data Registry list, look under AAOE Registry. Not the most innovative name, but that's our name. It's official. So we support 59 quality measures. That's more than we've ever supported. Last year was our first year. Last year we supported about 27 measures. So we've more than doubled the number of measures that we're supporting this year. The registry can accept multiple file formats, including the QRDA1, QRDA3, and the quality import form. So essentially, utilizing that quality import form, it's just a CSV file format. You go search for your denominator codes in the measure specifications, which we have all laid out for you within the registry itself, and then report the data, whether you actually did the measure or not, utilizing those codes that CMS has given to indicate whether you did it, an exception existed, or you didn't do it. And then we report that data for you over to CMS. We do have support available to help select measures. So that's myself, Vicky can help some, Daniel, our data analyst, can also help some. We're able to take a look at those codes, look at your billing history, see what kind of codes you're normally reporting to CMS, and tell you these are the codes that not necessarily that you should report, but these are the codes that you might be more advantageous to you. We can also look at the benchmarking that CMS has put out for certain measures, tell you what the scoring is going to be like for that, and let you know just how to maximize your participation in the MIPS program for the quality category. Feedback reports, we're focused on providing feedback reports at the very least quarterly. That's the requirement from CMS. That's what we want to be able to provide. So I think one of the issues that we had last year for reporting, everyone waited to the last minute to report their data to us. Mm-hmm. If you want to report through us, please don't do that this year. We want to be able to provide those reports to you throughout the year. So that, when it gets to October and your quality reporting is lagging a little behind what you feel it should, there's improvement that can be done over the coming weeks before the close of the performance period that can help you boost your score somewhat. We've got the orthopedic quality benchmarks. Those are in development. That's what we've been talking about this entire session. And then the AAOE Quality Payment Program Resource Center. So anytime a new rule is released from Medicare, the quality payment program rule is coming. They're not going to bundle it in with the physician fee schedule. I've heard like they did last year, which is fantastic news for me. I never say I enjoy reading 3,000 pages of CMS regulations, but so if they can split it out, that's fantastic. But anytime those rules are released, we try to add that information to the QPP Resource Center. So proposed rules released, we'll have that information up there. When the final rule is released, we'll have that information up there, as well as our quality payment program guidance for the year, which we've been doing now for since the creation of the NIPS program, we've been providing that guidance. The registry also supports collection of improvement activities. All activities are supported. It's just a simple attestation. You either did it or you didn't do it. And then the promoting interoperability category as well. The cost category, that's all claims-based. No registry can do that. So if somebody comes out and tells you we can report your cost data to them, tell them they're liars and that you're going to tell CMS on them because they can't do that. And then I think what's important is all this information is tied over. It's connected to power surveys. So like we've said multiple times now, there are many measures that require the completion of patient surveys, whether it's a visual analog scale. There's a bunch of the physical therapy measures require the focus on therapeutic outcomes tool. We don't have the photo tool in power surveys, but we do have several others, such as PROMIS, the HOOS and the COOS that are eligible for those quality measures. So any comments, suggestions, or questions about the registry itself, or even about MIPS participation in 2019? We can get really in-depth if you want to schedule an office hours visit with us. Anything? No? Okay.
I think we're ready for lunch.
Yeah, so just one last time, we just want to reiterate the goal of AAOE Empower, and even just this entire session, is just focusing on holistic practice improvement. So not just one particular area of your practice, but the entire practice. And even if you don't need to improve, that's fantastic, but just maintaining your top level participation, I think is very important, especially because, as has been mentioned, it's become very hard to remain independent or to be sort of at the top of your game for too long. And it's become very competitive out there. So just operating at that higher level is something that's going to ensure that going into the future.
Yeah,
okay.
So I was going to say, and you can go through the slides in your handouts that you have for the session. We have additional slides, and we can walk you through really how to get started with any system that's collecting all this data. So we're going to say, as Brad clicks through that, this information is available. We'd love to talk to you more about how to get started in the system one-on-one. I don't feel bad that we're flipping through these slides at the end because we had a lot of valuable, really great discussion today, and that was exactly what I was hoping for, that you guys had really good questions, that you were sharing with one another what was really beneficial to you, and what the next steps of that are. So if, you look at it and talk me through some of these last slides, I'd be happy to do that. At the Empower Station. So again, when the registration, it'll be on the Delta level, right next to the registration desk.
So one level down.
One level down from here. Look for the bright orange Empower Station booth. We will be there. We can answer questions. You can go spend more time on any of the topics that we talked about today. Walk me through those slides that we had to skip over. But again, don't feel bad that we did that because I really appreciate all of the interaction and the questions and the comments that we had today.
Yeah. If you want to schedule one-on-one time with us, please go to AAOE.net/office hours. And then if you're collecting CEUs, Vicki's about to flip over the sheet to get you the checkout.
That's what you were all waiting for.
I have a general question. How long do you have access to these handouts through the app? You know what I mean? Do you review the slides at the end of the day?
I
email them or save them? Is there a cutoff on that?
I think
there is. I think it's about a month. And then the app, it's not our limitation, it's the app developers limitation. They clear it out for next year.
Standing in front of the code. Can everybody see this? So let me read the code for everybody that's over there. 622-88AL0. You want to do that again? Can you hear me? 622-88AL0. Is it O? It took an O. Okay, so O. 622-88ALO. Okay. Yep.
And if you can't get it to work, we do have a manual sign-in sheet over here. So if you just want to sign in, we can manually add you to that.
And if anybody's having trouble with the app in terms of that check-in, check-out, we have a sign-up sheet up here that you could use and we'll process. If you have any questions, we'll be here for a couple minutes. Thank you all very much for attending today.